workshop. Sir, your presence here today will enlighten this event, and it is a great encouragement to us to carry out this type of work throughout the year. We consider you a great supporter for us in strengthening chemical pathology services all over the country, and your continuous support for our college activities is greatly appreciated. I welcome all the speakers of this workshop who are here with us today. Without your contribution, we surely would not be able to make this event productive and enriching. I also would like to welcome all the medical officers joining with us today. Your presence is an immense encouragement to all of us. Chemical pathology is progressing rapidly as a specialty with the highest impact on medical decisions. And you have become a part of that specialty by providing chemical pathology services throughout the country. Today and tomorrow, you will have the opportunity to listen to chemical pathologists working in large hospitals throughout the country, and I'm sure that this will be a valuable experience for all of you. Thank you.
We are privileged to have Dr. Sudha Dharmaratna, Deputy Director General of Laboratory Services of Ministry of Health, with us today this morning. So let me invite Dr. Sudha Dharmaratna to address you all.
Good morning, everybody. Can you hear me?
Yes, sir, we can hear you. Yeah.
Yes. Thank you very much, Dr. Richali, the college president, for inviting me for this workshop to give some remarks on the opening remarks. So I'm very happy with this workshop because it's a very important workshop. Dr. Kishali has taken steps to improve the quality of care of laboratories. That is why this workshop has been organized with the support of the Ministry of Health. Having gone through the two-day program, I noticed that there are very important topics and decided as the college, done by expert consultants like Dr. Gaya Katulanda, Dr. Tamara Hera, Dr. Iresh Singh, Dr. Majita, Dr. Dayanath, so on and so forth. So I must appreciate the college initiative because CPD is essential, and also improving the knowledge of the MO pathology is very important in this context. I also share some thoughts because I joined my career. At that time, there were only 4 MLTs and there were no consultants. So I was the only MO pathology. I had to work with the laboratory as well as I have to do some as an acting DMO. Then it's my fate after next annual transfer also I got MO pathology in Gampha Base Hospital. So throughout my career, 8 years, I work in a lab as a medical officer pathology. So I have a pride to stay with you today. All the medical officers in the medical laboratories are the participants. So I was one of them in the days gone by. Right? So I'm very happy because we are learning from the consultants. At those days, we didn't have any program how to update our knowledge, my knowledge. So we learned something by experience. And also at those days, the laboratory techniques are very primitive. Now we are in a very advanced level technologies there, and all are automated and analyzers are there. So you are very fortunate, not like me, because you have an immense support by the consultants as well. So you can harness the knowledge from this workshop and you can improve better, and also you can decide your future. So one of you will be sometimes maybe end up with a consultant in laboratory consultant, So sometimes you can end up with DD laboratory services sometimes, right? So there is a good opportunity. So having said that, I again thank Dr. Kishali, the president of the college, and other consultants who are supporting, giving resource contribution for this workshop. And don't forget, there are other specialties, for example, subspecialties like hematology, histopathology, microbiology, and chemical pathology. All are equally important. Those days I used to do the cut-ups on a piece of wood. That is the real scenario, right? Now I see when we go to the histopathology section, there are so many techniques that they are now. Tissue embedding machines are there, automated tissue processes are there, automated stainers are there. So every facilities are there now. So I think you can do a wonderful job, and you have to improve your knowledge as well. So without further ado, so I must thank the participants for joining from all over the country. So Director General of Health Services has sent these blessings and given approval and inform all the directors. That is why you are joining with this college activity. So we wish you all a very, very successful program, two-day program, and you can harness all the knowledge, and we will work together for a better future and improve our laboratory services. Thank you very much.
Thank you very much, sir. There's also a small notice to be made. We will be giving an e-certificate for the participants of this workshop, but those who have not registered before but have joined the workshop today, you can send your name to be appeared on the certificate and your email address on the chat box there. And so to continue with the rest of the workshop, I invite Dr. Gaya Kadulanda, Consultant Chemical Pathologist of National Hospital of Sri Lanka, to deliver her speech on Introduction to Chemical Pathology Testing.
Good morning, Dr. Sudat Dharmaratne, DDG-LS, Ministry of Health, President Dr. Kisali Hirimutugada, President of the college. And first, I must thank the College of Chemical Pathologists for giving this opportunity to me to address the MOs in this special program. Can I know that? Can you all hear me?
Yes. Yes, madam, we can hear you. Yes.
Okay. So today my topic is Introduction to Chemical Pathology Testing. I thought that I will briefly describe functions of a chemical pathology laboratory, role of the chemical pathologist and the medical officer in a chemical pathology laboratory, and introduce few common test methodologies and discuss about their principles, salient features, advantages and disadvantages, which I think is useful for the medical officers during their day-to-day activities. So what is chemical pathology or clinical biochemistry? So this is also a very important field. Actually, this is the bridge between medicine and science. As chemical pathologists, we do analyze body fluids of humans. to detect or measure constituents in body fluids using chemical methods. So we receive a large number of samples a day to a chemical pathology laboratory, and we use manual methods and fully automated analyzers to generate reports. Actually, 60 to 70% of medical decisions taken in the wards or clinics depend on our reports. So the clinicians use these reports to diagnose, monitor, screen, or predict prognosis of disease. So actually, we are a hidden service behind the cure. So let me take you through functions of a chemical pathology laboratory and phases of testing. So there are 3 phases: pre-analytical, analytical, and post-analytical. Actually, when a doctor sees a patient, he takes the history and does the examination. And obviously, if he has a clinical question, then next step is ordering tests. So he selects the tests to order, then prepares the patient and collects the sample and sends the sample to the lab. In the lab, we receive the sample and analyze it and produce a report and add interpretative comments and pass this report to the physician or clinician again. Then this analytical phase and processing of samples in the lab are directly under supervision of a chemical pathologist. At the same time, chemical pathologist is responsible for selection to help, has a responsibility to help the clinician to select appropriate tests and advice on, to give advice on patient preparation and instruct about sample collection and sample transportation. And chemical pathologist has a role to in reporting and interpretation, adding interpretative comments. So a chemical pathologist has dual roles. One is to lead and direct the chemical pathology laboratory. So chemical pathologist is responsible to start new tests depending on the need, evaluate and validate test methods, implement them, acquire equipment and consumables, maintain appropriate environment, train staff, and to authorize and report results. So another important duty of chemical pathologist is quality control of analytical method, which includes internal and external quality control. And additionally, we are responsible for quality assurance in all 3 phases: pre-analytical, analytical, and post-analytical. So what is the other role that is also equally important? That is liaison with clinical staff. So the chemical pathologist is the person in the medical field who has the best understanding of biochemical changes that occur in the diseases and about the test methodologies. So they could advise the clinicians on selection of tests, interpretation of test results, and they can comment on clinical significance of tests and about patient preparation, and chemical pathologist should be an active member in a multidisciplinary team. Then what is the role of the medical officer in a lab? So we don't have medical officers, chemical pathologists in all the labs. And but in all the labs, when there is a chemical pathologist, obviously there is a medical officer. So they also have to liaise with the clinical staff and provide information on selection of appropriate tests and to perform clinical validation of reports. And medical officers are involved in interpretation of test results and clinical authorization as well. And they advise on patient preparation, and they have to instruct the ward staff on sample collection and transport. In doing so, they should gain some additional knowledge about tests, test methodologies, principles, their interferences, and quality assurance. So the aim of this workshop conducted by our college is to enhance the knowledge of medical officers about testing, so the service can be more useful to the clinicians. These are the common test methodologies used in a chemical pathology laboratory: spectrophotometry, immunoassay, ISC, HPLC, electrophoresis, and we do perform manual methods as well. So in spectrophotometry, light is used in measuring substances. So as you all know, light is a spectrum of different wavelengths. So the basis is certain colored chemical substances or molecules absorb light at specific wavelength. So this absorbance is proportionate to their concentration. So what we do is we don't have colored products in blood. So we convert constituents in blood such as glucose, cholesterol, bilirubin, enzymes like AST to substances which are colored and which can absorb light. And we do this conversion using a series of reactions. This shows how glucose is converted to a colored product using cascade of enzymatic reactions. So ultimately, this O-dianisidine is produced, which is a colored product which can absorb light. So this reaction takes place in a transparent reaction cuvette. This shows a single cuvette used in an old-fashioned spectrophotometer and multiple cuvettes used in fully automated analyzers. So a beam of light of specific wavelength is passed through the cuvette. So this shows a very basic diagram of a spectrophotometer. There is a light source and there is a prism which selects a light of specific wavelength, and it is directed to the cuvette where the colored product is formed. And then there is a detector which measures the transmittance of light. So the products made out of reaction in the cuvette absorbs light and we measure the transmittance. And by measuring transmittance, we can calculate the absorbance. So amount of absorbed light is calculated. So this absorbance is directly proportionate to concentration. So, but doing so, how can we measure it? So we prepare a series of glucose solutions with known concentrations and we plot the absorbance against concentration. Then you get the calibration graph. Then we have the calibration graph. So we are ready to analyze. Then we run the unknown sample and measure the absorbance. Then we plot this absorbance and then concentration can be calculated. So this slide has analyzers in which spectrophotometry is used. In the middle is a simple spectrophotometer, and then you get two fully automated biochemistry analyzers. So these are the tests done using spectrophotometry. So to use spectrophotometry, the analyte should be present in considerable concentrations, such as milligram per deciliter, gram per liter, or millimole per liter. So when tests are done by spectrophotometry, cost is less, and now there are advanced and sophisticated instrumentation is available. So we can use very low sample volumes such as 1 to 2 microliters and generate highly accurate results. And this reduce interferences also to great degree. But there are disadvantages, but there are drawbacks. If color-absorbing molecules are present in serum, commonly we get hemoglobin due to hemolysis. If bilirubin or triglycerides are present, there can be positive interference due to absorbance of light. And if the cuvettes are dirty and if dust particles are present, then again, we will get wrong results. Some chemical substances may interfere with enzymatic reactions. So we try to minimize this, but there can be chemical substances, even sometimes unknown substances, which can interfere with this enzymatic reaction. So amount of colored product formed can be reduced or increased, giving falsely high results or low results. The examples are ketone bodies cause positive interference in creatinine assay by Jaffe method. Then hemoglobin causes a negative interference in glucose method by glucose oxidase. And citrate, if the sample is contaminated with citrate, so there is positive interference in phosphate assay. And if bilirubin, if patient has high bilirubin levels, there can be negative interference on creatinine method by Jaffe. So these are very common things, but there are a number of interferences. So actually now most of them are minimized, but still you can see these things on and off. So that's all for spectrophotometry. And then we'll move on to immunoassay. So in an immunoassay, antibodies are used as reagent. So antibodies capture the analyte of interest. So these assays are highly specific and when due to highly purified monoclonal antibodies. Antibody antigen reaction is followed by generation of a signal, and we use different signals. So because of this signal generation, we can detect or quantify the analyte. So this is a very simple diagram. There is capture antibody, and then antigen binds to the capture antibody, and there's another antibody which has a signal. So here the signal is fluorescence molecule, and then after binding, this fluorescent label produces a light, and then so this light is measured. So light is very much linked to chemical pathology. Then there are different signals. Earlier we used radioisotopes, which are obsolete now, and there are enzyme signal labels. So when enzyme is there, substrate is added and converted to a colored product, and again absorbance is measured. When it is fluorescent label, then it is excited and light is emitted. And in chemiluminescence, label is enzyme, and that triggers a chemical reaction where light is emitted. Now there are more sophisticated techniques named enhanced chemiluminescence or electrochemiluminescence, where these assays are very, very sensitive and accurate. So these newer assays are very sensitive and accurate, and that is, they have gained the ability to detect very low levels. That is how we measure we have third generation assays, which detect TSH at 0.001 level. And then the newest development is highly sensitive troponin I. So where we can measure very low levels of troponin in the normal population, and so even a very slight increase can be detected with confidence. So that is why early diagnosis of myocardial infarction, even without ECG changes, we can detect myocardial infarction very early due to availability of high sensitive troponin I, due to evolution of like signals in the immunoassays. So this shows calibration curve of an immunoassay, which is curved, and there are disadvantages as well. There can be interferences due to presence of antibodies in human blood, in the patient's blood. This can be negative or positive, depending on the design of the assay. So the antibodies used in assays are from animals like mice, sheep. So humans have anti-mice or anti-animal antibodies. And in addition, they have heterophil antibodies or autoantibodies. So all of them can interfere. And rarely there can be cross-reactivity with molecules with structurally similar molecules. The best example is prednisolone, which is structurally similar to cortisol, can interfere in cortisol assay. And there's another interference called high-dose Zook effect. This is very rare now. But it happens when the concentration of analyte is very, very high, as in a tumor marker, very high, then you get a very low result. So you are totally misled by this very low result. And now the emerging, there's an emerging form of interference called biotin interference, because biotin is a very common constituent of reagents nowadays. So, and people also take biotin very frequently. In Sri Lanka, it is like included in many preparations which can be purchased over the counter. So patient doesn't know whether he is taking biotin or not. And if we take blood when biotin concentration is high, we can get falsely high or falsely low results depending on the assay design. So we have to have these things at the back of your mind when you are interpreting immunoassay reports. So these interferences are totally unpredictable. And when we have to suspect them when results are incompatible. Imagine if TSH is very high and then T4 is also very high. So then we have to think about interference. So there are certain things we can do. We can rerun the sample in a different platform, and we can run it in dilutions and do a PEG precipitation to identify these interferences. So these are the tests performed by immunoassay, commonly hormones, tumor markers, and other metabolic markers. So these analytes are present in actually considerably low concentrations, such as microgram per liter or micromole per liter. So that's like those are the important things in immunoassay. Then we'll move on to ISC, or ion selective electrode, and the technique or principle we use is potentiometry. So this shows a very large reference electrode system. So the same principle is used in our automated analyzers. So this ion selective electrode is the key thing which can select ions we want to measure. So here the electrode is miniaturized. Still, we can't put the sample directly. So sample has to be diluted many times inside the analyzer. So this is called indirect analyzers. So most of the automated analyzers have indirect ISC. So they get the result and then they back calculate using the dilution factor. So result from the machine is multiplied by the dilution factor. So there is a very common disadvantage of this multiplication. This is called electrolyte exclusion effect. When the solid content of serum is unexpectedly high due to high protein, triglyceride or immunoglobulins, but still the analyzer uses same dilution factor, which is for normal serum. So then you get abnormally low results for electrolytes such as sodium. So that is why you see pseudohyponatremia in patients with high immunoglobulin, high protein, or high triglyceride. So this is avoided in certain ISCs, which are called direct ISC. So this is available only on the dry chemistry analyzers. You can see it is more and more miniaturized, and you can't see it used by your eye. So using this, you don't get this pseudo hyponatremia. So we'll move on to the next technique. So these techniques are becoming more and more sophisticated. So HPLC, or liquid chromatography, is a special technique of measuring chemical substances in a sample. So it has two phases, stationary and mobile, and solutes travel in the mobile phase through the stationary phase. So actually I have a small video clip for you to show. So this column is packed with the tiny particles. This is called the stationary phase. And imagine this is the sample, serum or whatever. And this is applied to one end of the column. And then you get the mobile phase. And then this mixture travels through this column, and different types of solutes or analytes have different velocities. So they can be separated, and these separated things can be measured. So this is the basic principle of chromatography. So the commonest analyzed we measure using HPLC or liquid chromatography is HbA1c. So the time that comes out of the column is the thing to identify the analyte. So HbA1c comes out after 0.78 minutes. So that is how we identify HbA1c. Then we calculate the area and then express it as a percentage. So we measure many more analytes using HPLC, but routinely we don't do that. Many drugs and other metabolites can be measured using liquid chromatography. Then we use electrophoresis. This is also we use like at a primitive level only to measure serum protein electrophoresis in a routine laboratory. So here an electric field is applied and sample constituents migrate and separate as same as in chromatography, but here it happens depending on their charge and size of the particles. So this shows the apparatus, and this is a normal electrophotogram, and this is an abnormal electrophotogram with the monoclonal band. So the use is to detect monoclonal band. So these are the sophisticated techniques we use, but we have not forget the manual methods yet. So these are also very important. So when it comes to body fluids such as urine, we check. The chemical pathology laboratory is responsible to check cells, casks, and chryses, and they give valuable information about the site of the pathology and the pathogenesis. And we measure counts and type. And then CSF is another very important body fluid, and we measure cell count, glucose, proteins, and look at organisms. And this slide shows India ink stain of Cryptococcus neoformans. Actually, we get samples like this. And then pleural fluid is another important sample we get very frequently. And clinicians are very keen to get the correct result because the treatment heavily depends on our report. So we measure protein, LDH, cell count with differential, glucose, pH, ADA, amylase, triglyceride. And here it's not mentioned, we measure cholesterol and like most of and other analytes and tumor markers. And this is a rare thing, but we do analyze joint fluid frequently now, do cells, LDH, microscopy, and we can diagnose this only by doing microscopy. So using a polarized mic, the upper slide shows calcium pyrophosphate crystals under polarized light, and the lower slide shows urate crystals. So I think this is like chemical pathology is not only dealing with machines and automation, but you need human touch as well. Then we have come to like the final slide. So chemical pathology laboratory plays an important and invaluable role in managing disease. And this is not limited to generation of accurate test reports out of samples we get. So we do extend our services to clinical colleagues by providing important information so we can together provide much more effective clinical service. So medical officers play a crucial role in doing so. So I think So I have come to end of my lecture. And thank you. If you have any questions, I am ready to answer those.
Yeah, sure, madam. So if you have any questions, you can ask now. Okay, in the absence of any questions, we will proceed with the schedule. Thank you very much, madam, for that informative lecture. So our next page is regarding quality control. Quality control in chemical pathology is an important aspect. So let me invite Dr. Tamara Hera, consultant chemical pathologist of Medical Research Institute, to give her speech.
Hello, can you hear me?
Yes, madam, we can hear you.
Can you see the slides?
Yes, we can see your slides. We can see the slides, madam.
Okay. Good morning and thank you for the kind introduction. Uh, Today my lecture is on quality control in chemical pathology. So in the next half an hour or so, I am going to discuss this topic under these headings. What is quality? How do we achieve quality? Internal quality control and external quality assessment. What is quality? Quality refers to the satisfaction of the needs and expectations of users and customers. Quality control system is a reliable, stable, documented system that supports continuous quality improvement. Components of there are basically two components of quality control: internal quality control and external quality assessment. So how do we achieve quality? As you know, when we test samples, it begins from the pre-analytical phase and going through analytical phase, and it ends in post-analytical phase. So likewise, quality also begins once the test is ordered by the clinician and ends when our test report is received by the clinician. So there should be we should maintain the quality throughout this process. So we'll first see what is internal quality control. For internal quality control, there are quality materials. These are specimens that are analyzed for QC purposes, and they are in liquid form or lyophilized or powder form. And when we talk about quality control, there are two terminologies you have to know. One is accuracy and the other one is precision. Accuracy is the closeness of agreement between the result of a measurement and the true value of the analyte. Although we talk about accuracy, what we measure is percentage inaccuracy. Suppose we have a internal quality control sample and we run in our assay. Then we get a value, that is the measured value. And this true value is the target value given by the manufacturer. So percentage inaccuracy is the difference of true value and the measured value divided by true value into 100. Then precision, that is the closeness of agreement between independent results of measurements obtained under specified conditions. For that, we can run a QC 20 times in a single run. But what we practice in day-to-day life is we run QC, the same QC over a period of time, that is daily. And once we got adequate number of results, at least there should be 20 results, we calculate mean and standard deviation. So precision is we can either get standard deviation or coefficient of variation. I think this coefficient of variation you know already from your community medicine appointment. That is standard deviation divided by mean into 100. So once we calculate the mean and standard deviation, we have to draw a Levy-Jennings chart. Most of the time with our fully automated analyzers, they give us Levy-Jennings chart. But when we use spectrophotometry, we have to draw these charts. So I think I should teach you this. And remember, for a single analyte, suppose serum potassium in this case, we have to have a Levy-Jennings chart for each level of QC. If there are 2 levels like normal or pathological, we should have 2 Levy-Jennings charts. So in this case, our mean is 4.1 millimoles per liter. So this red line indicates that. Then our SD is 0.1. So to draw this chart, to get 1 SD, we have to add that standard deviation to our mean. 4.1 plus 0.1, 4.2. Like that. We have to add each time one standard deviation value to get the other standard deviation. Plus 1 SD, plus 2 SD, and plus 3 SD. To get minus 1 SD, what we have to do is we have to deduct SD value from the mean. Likewise, we can get up to minus 3 SD. So there should be SD levels from plus SD to minus 3 SD. So this is the Levy-Jennings chart. And the horizontal axis indicates the days. So once we create Levy-Jennings charts, we have to apply these Westgard rules to see whether our analytical process is in control. So these rules can be used individually or in combination to evaluate the quality of analytical runs. Let's see one by one. You can see here on day 1, day 2, and day 3, all the QC results are within 2 SD limits. They are within plus 2 SD to minus 2 SD limits. But on day 4, it goes more than 2 SD level. That is what we call 1-2S rule, because a single level of QC a single QC value is more than 2 SD. So in this case, it gives us a warning, but still we can issue our reports. It wants us to see the next QC run to see what will happen to that. Here you can see day 1, day 2, day 3, day 4. All QC values are within 2 SD limits. But on day 5, it's more than 3 SD. At this time, you have to find the cause for this. And you have to correct that. After correcting that, you have to rerun the QC. If it falls within these 2 SD limits only, you can run your routine samples. So that is 1 3S rule. One value more than 3 SD limit. Here you can see this is for serum electrolyte for level 1 QC. On day 1 and day 2, they are within 2 SD limits. But on day 3, it's more than 2 SD. So it gives us a warning. So we look for the other day. The next day, again, it's more than 2 SD. So there are 2 consecutive values more than 2 SD. That is called 2-2S rule. So on the second day, we have to have some action, take some action. We have to take some action. So we have to find the cause and correct it and rerun the QC. And once it is within the 2 SD limits only, we have to run our routine samples. So the same thing for level 2. If the laboratory runs 2 levels of QC, level 1 and level 2. So you can see here on day 1, day 2, day 3, it's more than 2 SD for level 1 QC. And again, in the same run, on day 3, it is also more than 2 SD. So when we combine level 1 and level 2, there are 2 QC values more than 2 SD. So at this time, on day 3 itself, we have to take some action. Because our level 1 QC and level 2 QC, both are more than 2 SD limits. So you can apply this QC rule for 2 levels at the same time, or if you run a single level of QC, you have to wait till the next QC run. So this indicates the importance of running QCs more than 1 level. In that case, we can see our error earlier and do the corrective action earlier. Here you can see for level 1 QC, it is more than 2 SD. In the same run, for level 2 QC, it is less than minus 2 SD. So for level 1, it is more than 2 SD. And in the same run, for level 2, it's less than minus 2 SD. So there is a difference of 4 SDs between these QC results. More than 2 SD to minus 2 SD. So the difference between 2 QC results are more than 4 SDs apart. That is called R4S rule. In that case also, we have to take some action. We have to correct our run, then rerun the QC. And once it is within the acceptable limit only, we can run our routine samples. Here you can see all the QC values are within 2 SD limits, but all of them are more than 1 SD. So we can wait up to day 4. All these results are more than 1 SD, and we can wait up to day 4. But on day 4, we have to take action. We have to correct that. So that is called 4-1S rule, because there are 4 values more than 1 SD. The same thing can happen in this range also, between -1 SD to -2 SD. Again, we have to do some corrective action on day 4. So that's about applying Westgard rules on Levy-Jennings chart. Next, we move on to external quality assessment. It is intended to verify on a recurring basis that laboratory results conform to expectations for quality required for patient care. So it is intended to verify our results. That means we can get a clue that our results are accurate or not. And it is performed on a recurring basis, either monthly or 3 monthly or 6 monthly, whatever frequency, it should be done on a regular basis. And it assures us whether our reports are quality ones or not. And it objectively checks the laboratory's performance using an external agency or facility. So our results are checked by an external body, and it objectively checks the laboratory's performance. That means they give us a value, a number, where we are, not just saying you are good or bad. And it compares laboratory results with a reference laboratory or a peer group of laboratories' result, depending on the external QC material used. Let's see the process of external quality assessment. So once a laboratory gets registered in an external quality assessment program, the laboratory receives samples at regular intervals from a EQA provider. Then the participating laboratories analyze the samples and return their results to the EQA or proficiency testing provider before the deadline. Then results are evaluated and analyzed, and the laboratories are provided with information about their performance and how they are compared with other participants. The participating laboratories make appropriate changes and improvements accordingly. So we have to go through the EQA results and check our methods are acceptable or not. If they are not acceptable, we have to find the cause for that, and we have to take corrective actions. So this is an example of an EQA report. Actually, this is given by the Department of Biochemistry at Medical Research Institute. You can see here the each laboratory is given a lab code, a number, then the cycle, year and the month, the specimen date and the specimen number. These are the tests the particular lab is participating, their units, then the number of labs participating for a given analyte. Then you can see there are different names, truncated mean and truncated SD. This is because when we analyze the results, we get, for example, plasma glucose. We take all the results and get the calculate the mean and standard deviation. From that, we exclude extreme outliers. After that, we again calculate the mean and ST. That is why it is called truncated mean and truncated ST. So here, the laboratory results are given here, and you can compare it with truncated mean. And this is the standard deviation index, percentage bias, and accuracy index. As an MO, you have to have some idea on how to check these reports with regard to the acceptance. Usually, it's the allowable limits are given here. So from that, you can go one by one. This is standard deviation index. It should be between -2 to +2. So here you can see in this SDI column, all the analytes are within acceptable range except creatinine, which is less than -2. Then the accuracy index. It is given here. It should be -200 to +200. So here, most of the results are within acceptable limits, but except for total protein, which is more than 200, and creatinine, which is less than -200. Then overall accuracy index should be less than 200. It is given here. That is when we take accuracy indices for the whole sample, how is that cycle? How is our overall performance? Here it is within the acceptable limit. Here you can see another EQA report. There are several sections, a histogram and some graphs here. So from that, this is one part. Let's see this example. This is for glucose given in milligrams per deciliter. They give mean value for all methods, for all the participants. And this is for the method we do, hexokinase. There's a different mean. And for the specific analyzer, there's a different mean. So this is your result. And to evaluate this report, there are acceptable performance criteria given from them. One is standard deviation index. It should be less than 2. And the other one is target score. It should be more than 50. And percentage deviation, that should be less than the defined acceptable limits. Let's go one by one. This is our result. This is standard deviation index, minus 1.26. So it is less than 2, acceptable. Target score here is 120. So it is more than 50, very good. Then percentage deviation is minus 1.2. And their defined acceptable limit is here, 7.5. So it is also acceptable. So likewise, we have to basically see these acceptable performance criteria for each analyte and check whether they are within the acceptable limits. Then once we have gone through the EQA report, we have to see when our performance are not acceptable, then what are the causes? There can be several causes. One is clerical errors. This can happen when the MLTs enter the report incorrectly put in the decimals, then incorrect measurement units like that. Then there can be methodological problems like calibration problems like that. Then equipment problems. The lamp may be deteriorating. Then there are maladjustment of probes like that. Then technical problems caused by personal errors. The most common error we can see is pipetting error. Then there can be a problem with the proficiency testing material itself. Once we receive the EQA material, it can be decomposed. In that case, all our results get wrong. So these are the causes of unacceptable EQA results. So we have come to the end of the lecture. These are the key messages. You are a part of a quality management team. Be responsible to issue a quality report for proper patient management. Thank you.
Thank you, Madam. So if you have any questions, you can ask now. So in the absence of any questions, we will proceed to the next speech. Critical values, complaint handling, and improving the quality of the laboratory are equally important aspects in the field of pathology. So let me invite Dr. Sakuntala Jayasinghe, Consultant Chemical Pathologist of University of Peradeniya, to deliver her speech on this very topic.
Can you see the screen?
Yes, we can see, yes.
Okay, thank you. Good morning. So I'm going to talk about today some very basics of improving the quality of the laboratory and two important components within the quality framework, handling critical values and complaints. In my talk, I'll be talking about what the quality is with regard to clinical laboratory, components of quality, and how can you as medical officers contribute to improve quality. And in the next section, I'll be talking about the definition of critical results and different aspects of critical results and the importance of communicating critical results. And in the third section, we'll be talking about the need for handling complaints and the correct procedure of handling complaints very briefly. So first, let's look at the total laboratory quality and quality improvement process. So as we all know that the laboratory plays an important role in detection of disease, diagnosis, and treatment. It is because the decisions the clinicians take during patient management or treatment protocols, detection complications, and when deciding to admit or the discharge patients are most of the time based on the results provided by the laboratory. So the users of the laboratory, that is the physicians or the patients, expect accurate, reliable, and timely results from the laboratory. To give such results, we have to assure the quality of the test results that we give out from the laboratory. So the quality assurance means the coordinated process of providing the best possible service to the patient and the physician by the laboratories. So this whole process includes monitoring and controlling of the competency level, or how good they carry out the work of the personnel working in the laboratory. Also, the material we use, methods we use, and the reagents and instruments we use in the laboratory to carry out the results. And then how we reliably report the results we produce at the laboratory. So when we talk about quality assurance, we talk about this quality assurance cycle, which is in 3 phases: pre-analytical, analytical, and post-analytical. The pre-analytical phase starts with patient preparation and sample collection and goes on to sample transportation until the samples are received at the laboratory for testing. And during the analytical phase, which is the actual testing phase, to maintain quality, we make sure the people, competent people are doing the test and the processes are in good place, in good quality. And then we control the quality by internal and external quality procedures. And once we receive the results from the analytical system, it goes into the post-analytical phase, which is issuing a report, printing a report, keeping the records, and until the reports are received by the patient or the requesting physician. So when we talk about the quality, total quality of the laboratory, we also talk about this quality management system, which is actually defined by the Clinical and Laboratory Standard Institute and various other ISO guidelines, including ISO 15189, which is the ISO standard for the medical laboratories. So this includes 12 essential components, this model, and it has been adapted by the medical laboratories worldwide to improve the quality of the laboratory. So these are the 12 components of the total quality management system, which include every process, every activity that happens within the laboratory, and make sure that the quality of each of these process is maintained, monitored, and evaluated, and in the standard at a standard acceptable levels. So from organization to safety to people working, equipment, reagents, and everything is included in this total quality management system. And in the accreditation processes, all these aspects are looked into. So according to WHO definition, the total quality management is a total process whereby the quality of the laboratory reports can be guaranteed. So they summarize this as the right results given at the right time by the laboratory within an acceptable time limit, on the right specimen, that is collected at the right specimen, right tube, in the right tube with the correct patient preparation and so on, from the right patient, ensuring that sample mix-ups don't happen, and also with giving the correct reference data so the results can be correctly interpreted, and at the right price, even though because of the free health, we don't talk much about the price, but this is also an important component of ensuring a quality report, giving the test results out at a right price. So what is actually quality of these test results? So when we talk about the quality of our results, we expect that it fulfills certain requirements set out by accepted standards like ISO 15189. In another way, the quality also means the results of one lab is compared to the results of another lab to assure which is of better quality, to make sure which is of better quality. So if results have got good quality, if laboratory has good quality, it is like a reputation. To develop a good quality laboratory, it takes a long time and also a lot of effort, but it can be ruined with one error within a short time. With one error will destroy the reputation of a laboratory. But if you have a good quality test system, there will be very few adverse events, very few errors, and very few regulatory failures. On the other hand, if there's poor quality, that will result in more adverse events and failure, and will cost more to the laboratory with those failures and errors. And the worst part of it is it can cause considerable harm to the patients. So in the quality improvement process of a laboratory, we talk about these three components, which I had been sort of explaining in a very broad manner, with the total quality management system with 12 essential components within the laboratory activities, and then the quality assurance cycles, which include mainly the workflow pathway of testing process, which includes pre-analytical, analytical, and post-analytical phases. And then the quality control component, which is only maintain the quality of the analytical part by internal quality control procedures and external quality control procedures. So how, as medical officers, you can contribute to this total quality management and improving the quality control of the laboratory? You can definitely assist in the quality management process by developing SOPs, maintaining documents, training the technical staff and other staff, and also contributing to QC procedures and method validation and other technical aspects of the laboratory processes. And then you can advise in patient preparation to the clinical wards or the outpatient departments, doctors, when we request, especially for dynamic testing and specialized testing, and also sample collection with regard to the correct tube, correct collecting material, collect additives and so on. You can definitely contribute by advising in sample collection. And when you come across certain results, maybe abnormal results, you can suggest further testing to the clinical units. And also sometimes you can add test to the existing blood sample at the laboratory. For simply as an example, if you see a low calcium in a blood sample, if magnesium is not done, you can definitely add the magnesium testing, since especially it is easy with the free health, because we are not charging patients. Without consent from the clinical departments, it is perfectly okay to add certain testing to existing blood samples if you find it clinically appropriate. And definitely you can assist in interpreting results, especially specialized testing, and you can add interpretative comments to the reports. This may not be very easy if you don't have much clinical information, but with the improvement of the clinical communication and these things, you can find out about the patient clinical conditions and add interpretative comments to the reports. Then we will talk about critical results handling. You can definitely, you are the medical officers are very important, because identifying critical results are easier for medical personnel than technical personnel in a laboratory, especially in the context of the clinical information available. And then investigation, laboratory errors or complications you can contribute. Regular internal audits are a necessity in accreditation processes and quality improvement processes. So you can contribute by doing regular internal audits. And also importantly, you can prevent unnecessary testing and contribute to demand management of the laboratory, especially for certain, maybe not for all routine testing, but certain specialized testing. You can vet the request, you can decide whether to accept the sample for testing or not, and thus contribute to demand management. Okay, with that, let's move on to critical results and their notification, which is a very important part in improving the quality of the service provided by the laboratory. What is a critical result? So again, by definition, a critical result is any value or interpretation for which if there's a delay, it can result serious adverse outcomes to the patient, or it can also could result in significant morbidity to the patient. Therefore, requires urgent action. It may not only be laboratory results, it could be investigation results provided by the cardiology units, radiology units, or any other diagnostic testing service providing units for patients from the inpatient, outpatient, emergency, or any setting. Okay, so there are so many names called for these critical results, like critical values, panic values, critical alarms, alarm values, and so on. And for the critical results, there are actually two components, namely critical test or a critical limit. A critical test is a test which requires rapid communication to the requesting person, irrespective of whether the results are abnormal or normal or critical. For example, usually the troponin results requested by the emergency departments, A&E, or maybe paracetamol results requested by the A&E, we usually results sort of inform the results irrespective of whether they are normal or abnormal, because to take the next step in the patient management, these units need these results immediately. On the other hand, critical limit is where we define the upper or lower boundary, which defines beyond that, if patient has results beyond that limit, that requires prompt action by the treating physician. Or it also could be a change of a result within a critical time scales. For example, in a for a creatinine results, a certain level beyond which within a 24-hour or 48-hour period, more than 26 micromoles per liter, for example, such a change could be an indication of acute kidney failure. So such results also must be communicated to the requesting person immediately. So there are two components in this critical result communication, that is identifying critical test and identifying critical limits. In association with the critical result notification, there are other definitions like significantly abnormal results. These are not life-threatening results, but they need attention and follow-up action by the physician as soon as possible. But timing is not as crucial as critical results. Again, for example, if you come across a very high PSA level in a patient who has a history of lower urinary tract symptoms, that might indicate a prostatic malignancy in this patient, which was not identified before. So if this came from an outpatient department, and if you wait until the patient comes back for the next clinic, it might take several weeks. So to prevent that, you can inform this to the clinician who requested, and they can trace the patient and quickly bring him down for further investigations and management. So those are significantly abnormal results, which are not as critical as time-wise critical, as in critical results. Okay, and there are urgent tests as well. Okay, so again, you have to identify the difference between the two terms, because urgent tests are usually decided as urgent by the requesting doctor based on the patient's clinical condition. So at the laboratory, we process them urgently and the results are communicated urgently, because if we wait for the normal reporting procedure, it will take time. So we communicate them irrespective of whether they are normal or abnormal. As opposed to that, critical results are usually not identified the requesting clinician as urgent, but the laboratory see them as critical results after non-urgent analysis. And usually the laboratory don't have a lot of information about the patient condition. Just based on the results value, you can decide whether it's critical or not, and then decide communicating them to the laboratory. 100% of the time, they may not be critical because we don't have all the information of the patient, but it's always safe to inform if we have defined them as a critical beforehand. Okay. So according to this World Alliance, WA publication of World Alliance for Patient Safety done in 2008, they identified that poor test follow-up as a major cause of harm for patients all around the world, even in the developed countries. And this poor test follow-up could manifest as delay in treatment or failure to treat patients with high laboratory results, or as failure if the patient is discharged. Most of the time, some of these results get lost somewhere and doesn't go to the primary care provider or the person who is taking care of the patient after discharge. So that is, so notification of critical results in a timely manner is quite important for patient safety, because one thing, this communication by the laboratory is accepted as a universally acknowledged role by the laboratory. So by doing that, they play an important role in promoting patients' safety, and they have a significant impact on medical decisions and subsequent patient outcomes. But the downside is these processes, post-analytical processes and result notification processes, are far less standardized, and they are prone to human errors or non-compliance most of the time, because sometimes the laboratory cannot reach the requesting physician. So after some time, they might give up trying to communicate. And sometimes it is given to somebody like a nurse or a ward manager or somebody, which they might not communicate properly to the doctors. So these errors can occur in the process, and the laboratories are continuously talking about improving the procedures for critical results notification, because they can threaten the patient safety and also can lead to litigations. And now with accreditation, it is a legal requirement by all the accreditation bodies and the clinical laboratory improvement amendments. So laboratories should have written policies and procedures for critical value reporting, and they should have documentation of actions taken when they come across critical results. So usually it is there are published list for critical tests and critical limits, but it is always advised for each laboratory to develop their own critical limits for each testing, because the sample types of tubes and the analytical platforms may differ from laboratory to laboratory. And these deciding critical limits and tests must be done in agreement with the clinical colleagues of the hospital. But 100%, according to a lot of surveys, it have shown that 100% of the time this is not happening. But it is very important because these are the people who decide on patient management, and deciding the limit with discussions with them is quite important. So there are a few key elements of critical resource management. We have to have a definition of what the critical tests are and what their limits. For example, if it is potassium, anything less than 2.5 or anything more than 5.5 are as critical limits, just as an example. Okay, so we have to define what these tests and what the limits are. And then you have to have a procedure for notification, whom to, so like these components, whether you carry out the testing in a timely manner, how do you identify critical values, and how you communicate, whether it is by phone or email or any other method, and who can report critical results, whether the MLTs can report, whether only the doctors can report, or who can receive critical results at the other end. Is it only doctors? Can nurses receive results and then give back to the doctors, and so on? And how do you acknowledge the receipt of results, whether you read them back or whether you write down somewhere, and how from the warden, and how that should be recorded by at the laboratory end, because these things should be documented, that if you have communicated those results, that should be documented, and if you couldn't contact anybody, that also should be documented. All those things should be in written if you follow proper accreditation procedures. And in case of failures to communicate, what is your escalation procedure? What is the fail-safe procedure to prevent harm to the patient? Okay, so all these things must be think before, and there should be procedures to carry out in each situations. And these things should be documented, and the procedures should be reviewed and monitored regularly to evaluate the outcomes of the procedures. There are certain pitfalls with critical result information, because all the abnormal results may not always be always true results for the patients. For example, there may be certain pre-analytical problems in the sample causing erroneous or abnormal results. Say, for example, potential patient mix-ups. So if a very high creatinine came up as results where in a patient whose creatinine had been normal a few days before, you might inform this as critical results. But if there had been a sample mix-up from a previously chronic kidney disease patient, this may not be really critical. So it might lead to inappropriate management for the patient. So that has to be prevented. Similarly, there may be pre-analytical interferences like hemolysis, lipemia, interferences by certain medications, and so on. So these things may not be always identifiable 100% of the time, these interferences or errors, by just looking at the results or looking at the laboratory processes. But you should always keep those at the back of the mind for a possibility before communicating critical results. And also you should communicate this message also to the ward, also to check for mix-ups or any other possible interferences depending on the result you are communicating to the laboratory. Okay, let's move on to handling complaints. Complaints is an expression of dissatisfaction related to the related to any activity of the laboratory or results provided by the laboratory. So when somebody make a complaint, they expect a response or resolution of a problem. So complaints are usually indications that the clients have bad experience with the laboratory services. So you should take them seriously. These are often seen as negative criticism, but we have to, as laboratory personnel, we have to bear in mind that these are perfect indications for a point of improvement, because they are free of charge information about what can be improved of the performance of the laboratory, and they can be turned into training opportunities, and they allow the laboratories to learn and continually improve its performance and the quality. Again, we need these procedures and handling mainly because that will affect the patient safely, and also because it is a requirement by the accreditation bodies. So there are certain steps you have to follow in handling complaints. You can receive complaints verbally or as written complaints, and you have to always acknowledge the complaints in a very disciplined manner. And if necessary, if you think there's an error occurred, it's always very good to apologize to the complainant. And then you should start a technical investigation according to a predefined procedure to find out if actually an error has occurred, or if so, what is the root cause and other factors involved in the process. Once you identify an error, you can take corrective actions and can take preventive actions to prevent them occurring in the future. Once you have completed your investigations, you should give a feedback to the complainant, including the corrective and preventive actions you have taken. And all these things you did with regard to the complaint has to be documented in a proper format. And if you have taken any corrective actions, they should be reviewed in a regular manner to check whether that is actually have prevented such occurrences in the future. So basically, the complaints should be documented. They should be processed immediately, and the investigation should be closed in a timely manner. Okay, so that is so far for that. In summary, I would like to take these few messages home. So this continuous quality improvement of a clinical laboratory is a recognized necessity worldwide. As third world countries, we are moving very slow, especially in the government sector, but it is identified, and we are trying our best to achieve that, even though it's quite slow. Medical personnel in the lab can contribute to this quality improvement procedure in many ways and at different points in the total testing procedure. They are a very important bridge, you are a very important bridge between the clinical units and the laboratory technical personnel. Two important components you carry out as medical personnel are critical result communication and complaint handling, and that is doing that properly is very important for patient safety and quality improvement of the laboratory. And having systematic procedures for these things will improve the efficiency of the laboratory. That's all. Thank you.
Thank you, madam. If you have any questions, you can ask now, or you can type it to the chat box. So it seems like there's some questions. Okay, madam, thank you very much for that.
Thank you.
lecture.
Thank you.
For every participant of this workshop, we will be providing an e-certificate. So if you have not registered before and have joined the workshop today, you can share your name to be appeared on the e-certificate and the email address and share it on the chat box. And also all these lectures will be recorded and it will appear on our official website, College of Chemical Pathologists of Sri Lanka website after 2 days. So you can go through them again and if necessary, you can, it will be there for a while. So then to proceed with our workshop, we have our next page, which is on the interpretation of the liver function test. So let me invite Dr. B.K.T.P. Gayanath, consultant chemical pathologist, North Colombo Teaching Hospital, to deliver his speech.
Right. Good morning. Good morning, everybody. Can you hear me?
Yes, sir, we can hear you. Yes.
All right. Okay. First of all, I must thank President College of Chemical Pathologists and College Council for conducting this kind of program, as well as inviting me for this important topic, interpretation of liver function test in this program. And I must say this kind of programs are very essential for the development of like continuous professional development of knowledge of medical officers as well as trainees in chemical pathology. My topic is interpretation of liver function test. Now, before that, I would like to just go through the anatomy, not in detail, because now our body has 3 filters. One filter is our oxygen filter, which is lungs. All the air coming from the lungs, oxygen is taken in by lung, working as a filter. And the second filter is liver, because the nutrients coming through the gut first go through the liver, then liver do so many things to whatever the nutrients coming, amino acids or lipid things or glucose, and do a lot of metabolic activities and release into the circulation. And third filter is kidney, which is responsible for excretory functions. If one of these filters not working properly, as you are aware during last this COVID pandemic, if our lungs not working properly, our lives will be in danger. Same as liver and kidney, you are all aware about chronic renal failure. If a patient is having chronic renal failure, a lot of waste products accumulate in the body and result in acidosis and other metabolic discrepancies. Same as liver. Liver is very important, and because liver is the first organ, meeting foreign things coming to the body. circulation. Therefore, interpretation of liver functions. By interpreting liver function test, we can get an idea what kind of problem patient is having. So liver is located in the abdomen. As all you are doctors, you know this very well. And this is also very important. And liver, if we take histology, it consists of lobules. And our important part is this portal triad. It has portal artery, then portal vein, then hepatic artery, bile duct, and we have a central vein in the center of the lobule. And blood always bathing these hepatocytes. But most important thing is this. Now we have in the lobule, we have a central vein located in the middle, and all the blood coming from portal vein flows through this portal vein to central vein. Because in order to function these cells, we need this liver needs oxygen. Oxygen is carried by hepatic artery. Then the backflow is through the bile duct. Bile duct drain all the bile and other end products to the intestine through bile duct. In the portal triad, we have bile duct, portal vein, and hepatic artery. So, for example, if there is a ischemic injury, oxygen supply to this area, the distant area will not be affected, but this towards the central vein will be affected. If the liver is exposed to toxin, the mainly affected cell line will be cell line close to the portal triad, but will not much affected this cell lines close to the central vein. Like that, understanding this hepatic architecture, we can understand a lot of pathological complications in the liver. Now, if we take liver functions, it has metabolic functions, carbohydrate, fat and protein, secretory functions like bile, formation of bile, bile acids, salts and pigments, excretory function, bilirubin, drugs and toxin, synthetic function, albumin, coagulation factors. That's why we do assess protein levels, albumin level, and PTINR as coagulation factors in liver diseases. Then storage, vitamins, carbohydrates, then detoxification of certain toxins, ammonia, etc. Now we know if a patient is going into renal liver failure, patient end up with hepatic encephalopathy, which is due to accumulation of ammonia in the body, because the function of detoxification ammonia is disturbed in liver failure. So this is very important organ. Now, classifying liver diseases, we can different books classify liver diseases in different ways, but we can classify as congenital disorders like Gilbert's, Crigler-Najjar, Dubin-Johnson, Rotter, like congenital diseases, then hepatitis, acute hepatitis, chronic hepatitis. By looking at reports, we should be able to guess whether this is a acute condition of the liver or chronic condition of the liver. By interpreting, when I go through, I will explain how we can interpret. Then cholestasis, maybe intrahepatic cholestasis, something to do with the stasis inside the liver or maybe outside the liver. Then like cirrhosis, tumors, drugs, drug-induced problems in the liver. So, but different books can uh, classify in different ways, but it is easy to remember like this. Then we know we can interpret our liver function test very simply. Now, before ordering liver function test, doctors when they see the patient, they go through patient's clinical signs like presentation. Maybe a patient present with ankle edema, yellow discoloration of eyes, or maybe like jaundice, or maybe passing pale stools, maybe passing dark like tea colored urine, like different clinical signs give rise to think of liver problem. Then clinician or doctors in the ward, they in order to clarify whether this is a liver problem or not, they order liver functions. Usually when we say liver function test, we order uh, bilirubin total and conjugate, AST, ALT, ALP, gamma GT main liver enzymes, prothrombin time, total protein and albumin, globulin. Globulin is a derived parameter. Then other tests like in order to get idea, urine bilirubin, urobilinogenin, UFR. By looking at these investigation results, we can come to a conclusion what kind of liver disease, whether this is acute liver disease, whether this is a chronic liver disease, whether this is maybe due to a toxin, whether this is something to do with obstruction, intrahepatic obstruction or extrahepatic obstruction, like things we can guess. Now, if we take investigations, most unique investigation of the liver is bilirubin. As medical officers working in the laboratory, we should be able to interpret bilirubin results very carefully as well as like in detail in order to guess what the patient is having. Then if we take bilirubin, how bilirubin is formed? Bilirubin is formed by is a end product of hemoglobin. Like 100 red cell survival is around 120 days. After 120 days, red cells are break down, and hemoglobin is released. Of hemoglobin, this heme is converted to bilirubin in the reticuloendothelial system, especially in spleen, maybe bone marrow, and like areas. But this bilirubin formation has several steps. We don't have to know each and every step, but what is happening is this tetrapyrrole ring is open up and form bilirubin by using heme oxygenase and biliverdin reductase like enzymes. But the problem of bilirubin is it is not water soluble. It is actually fat soluble, or it has to be bound to a carrier protein like albumin in order to transport to the liver. From the reticuloendothelial system, bilirubin is bound to uh, albumin. It is taken into the liver. In the liver, it is converted to conjugated. This unconjugated bilirubin is converted to conjugated bilirubin by using glucuronide transferase enzyme and form monoglucuronide and diglucuronide. And end product is conjugated bilirubin. Once conjugated bilirubin is formed, it is transferred to the biliary caniculi to be excreted into the gut. This is what is happening for bilirubin. If there is a problem in this pathway at any time, you get different clinical features, and as well as different uh, parts of bilirubin elevation, like maybe total bilirubin elevated at one point, maybe total and total and conjugated bilirubin both elevated, or maybe predominantly conjugated bilirubin is elevated. I will explain. Now, same thing after red cell breakdown, unconjugated bilirubin come into the liver and it is converted to conjugated bilirubin. Conjugated bilirubin is excreted via biliary canicula into the gut, and in the gut, it is some part of the bilirubin is converted to strokobilinogen and urobilinogen. Then that's why our stool get colored. Then some part of the urobilinogen is coming back to the liver through enterohepatic circulation, and some part will leak into the kidney and excrete with urine as urobilinogen. That's why on standing, our urine get dark once urobilinogen is oxidized to urobilin. Same thing happens to stools. On standing, stools become dark, as well as stool becomes yellow color because of strokobilin. This is the end product of bilirubin. And this is the normal pattern. In the plasma, if we take bilirubin, unconjugated bilirubin is present in around 95%, and conjugated bilirubin is around 5%. But you don't need in details, but if you go through reference ranges, always unconjugated bilirubin is a little bit higher than conjugated, because once it is conjugated, it becomes water soluble and it is easily excreted from the liver, provided there is no problem in the liver. Then urine bile pigments, normally small amounts due to enterohepatic circulation, increased in liver disease due to inability to excrete the small amounts, reabsorbed from the gut, and in hemolytic disease. In hemolytic disease, urobilinogen formation is much higher, because you are getting more and more substrate to form urobilinogen. And decrease in cholestasis. If there is obstruction, you can't excrete whatever the formed urobilinogen, so it will be excreted in the, it will not go to the gut. Then bilirubin appears in urine when plasma conjugated bilirubin rises in any problems leading to elevated conjugated bilirubin. Now this picture is very important. Now if we take now we can now sometimes patient present with jaundice, yellow discoloration of eyes, but by looking at the patient, we can't say this discoloration is due to a hepatic problem or pre-hepatic problem or post-hepatic problem. In order to clarify whether this is pre-hepatic, hepatic, or post-hepatic, what we have to do is we have to do liver function test and get an idea about liver profile parameters. Then we can decide whether this is pre-hepatic, hepatic, or post-hepatic. Now, if it is pre-hepatic, for example, hemolytic jaundice, what is happening is unconjugated bilirubin influx will be much higher, and but there is no problem with the liver. So liver will conjugate whatever the bilirubin coming to the liver, and as there is no obstruction of the biliary caniculi pathway, whatever the conjugated bilirubin will be transferred to the gut. And but because this influx is much higher, the percentage of urobilinogen leaking into the kidney will be high, so you get your urobilinogen formation will be increased in urine. And once the liver is saturated, unconjugated bilirubin, because once the liver is saturated, liver cannot take more and more bilirubin. But once liver is taken bilirubin, it will be conjugated and excreted. Therefore, unconjugated bilirubin fraction will be increased with total bilirubin. If it is a prehepatic jaundice, or for example, hemolytic disease, you get unconjugated bilirubin increase in your blood. And also this is common in premature infants because their liver is not very mature, they can't take up whatever the all unconjugated bilirubin come into the liver, and some will be accumulate in the blood. So they also get, until liver is mature, they get unconjugated hyperbilirubinemia, which is very commonly seen in newborns. But if you are having hemolytic disease, your total bilirubin will be high. There won't be much derangement of liver enzymes like AST, ALT, alkaline phosphatase, or gamma GT, because there is no pathology inside the liver. And as liver excretory pathway, excretion pathway, intrahepatic and extrahepatic biliary canalicular, okay, the excretion will be smooth. Therefore, by looking at liver profile, and also there, as liver is functioning properly, total protein, albumin, there won't be much globulin, and all other parameters will be normal. So by looking at patient's liver function report, if you see total bilirubin high with total unconjugated bilirubin fraction high, that is most probably due to prehepatic jaundice. So we can go for differential diagnosis. But next one is intrahepatic jaundice. Intrahepatic jaundice means you get damage, some kind of damage, maybe viral attack, maybe toxin, whatever. You get damage to the, some kind of damage to the liver, because liver is damaged and hepatocytes swollen. Hepatocytes cannot acquire or cannot function as earlier, like as normal. So the conjugation will be little bit impaired. And also because maybe toxin attack or virus attack, there will be some kind of damage to the hepatocytes. So hepatocytes, once hepatocytes damage, the AST, ALT, which are liver enzymes, will be raised. And but whatever the bilirubin coming to the liver will be conjugated. But because these hepatocytes, once hepatocytes swollen, the biliary canaliculi will be blocked. So there won't be smooth excretion of biliary bile formed conjugated bilirubin to the gut. The some kind of leakage of bilirubin will occur into the circulation. Therefore, both total and total bilirubin, that means unconjugated and conjugated fractions, both will be elevated in when there is a hepatocellular damage, as well as there will be elevation of hepatocytes. But whatever the way, bilirubin is conjugated, some part of the bilirubin will be transferred to the gut, as there is no big obstruction, and urobilinogen will be formed. But main feature is liver enzymes elevated, total bilirubin elevated, conjugated and unconjugated both fractions will be elevated. This is called intrahepatic jaundice, or this is due to hepatocellular damage. And we commonly seen this in hepatitis, viral hepatitis, toxins, for example, like other conditions like maybe dengue virus, other viral infections. But important thing here, if we need to know whether this is an acute attack or chronic attack, we have to go to protein and albumin. If albumin level is low and globulin fraction is high, especially if albumin is low, that means liver is not functioning properly and not synthesizing proteins properly for longer period. That means it is more in favor of chronic hepatitis. Now, if you are infected with, if the patient is infected with hepatitis B and chronic hepatic damage is happening, and patient or maybe patient is having chronic alcoholic hepatitis or cirrhosis, they also may get reduced albumin level. It is a kind of chronic hepatitis. If it is acute hepatitis with these features, albumin will be almost normal. So by looking at liver function test, I will show you at the end, we can guess whether this is acute hepatitis or chronic hepatitis, whether this is intrahepatic or prehepatic jaundice. Now, some patients present with deep jaundice, but they don't get much damage to the much elevation of AST and ALT. There won't be much big elevations of liver enzymes, but gamma GT will be very high, alkaline phosphatase will be very high, and interestingly, total bilirubin very high with unconjugated fraction very high, because the liver is functioning properly. Therefore, unconjugated bilirubin, which is coming from the reticular endothelial system, can be converted to conjugated because there is no damage to the hepatocytes. But once it is conjugated, it cannot be excreted to the gut because maybe intrahepatic cholestasis due to a tumor or something, or maybe a gallbladder calculi lodging in the common bile duct, or maybe pancreatic tumor, whatever, obstructing common bile duct. In that case, all the unconjugated bilirubin will be leaked to the blood. So our report will say total bilirubin high, unconjugated bilirubin not that high, but the major fraction is conjugated bilirubin with markedly elevated alkaline phosphatase. Alkaline phosphatase markedly elevated because the alkaline phosphatase mainly present in this capillary biliary epithelial cells, as well as gamma GT is elevated because both ALP and gamma GT in this cell line. And stools, because there is no drain of bilirubin, conjugated bilirubin into the gut, there won't be coloration of stools. So stools will be pale color. But because conjugated bilirubin is leaking into the urine, urine will get dark color. So you get dark colored urine, total bilirubin elevation with conjugated fraction, higher conjugated fraction, markedly elevated gamma GT and ALP, then we can guess this patient is having extrahepatic cholestasis, or which is called obstructive jaundice. By looking at report, we can guess what is patient is having, and once report is going to the clinician can interpret and they can do further investigations. Now albumin. Next important test of liver is albumin. Albumin has a plasma half-life of 3 weeks. Therefore, serum albumin concentrations change slowly in response to alterations in synthesis. In practice, patients with low serum albumin concentrations and no further LFT abnormalities are likely to have a non-hepatic cause for low albumin, such as proteinuria or protein-losing enteropathy. This is very important. Once we see low albumin, we can't say this patient is having hepatic problem, synthetic problem, like me. But we have to check whether patient is losing protein in his renal tract. In order to do that, we have to do albumin. If albumin negative only, we can concentrate on liver. And as I mentioned earlier, albumin is very, very important because in chronic liver diseases, albumin synthesis is impaired. Now, enzyme release following injury, cell injury, inflammation leads to release of cytosolic enzymes, that is alanine aminotransferase, ALT and AST. Liver obstruction induces synthesis of membrane-bound enzymes, that is alkaline phosphatase and gamma GT. And bile salts facilitates their release into plasma. Now, ALT, AST, leakage of enzymes into the circulation. ALT, liver predominant. AST, liver, cardiac, and skeletal muscles predominant. For example, and also AST present in red cells. That is very important. If we once the sample received by the laboratory and if we delay separation, if the sample is hemolyzed, you get marginal elevation of AST. As marker of hepatocellular injury, AST and ALT also lack some specificity because they are found in skeletal muscles as well. So we can't just say, when we see high AST, ALT, especially high AST elevation, it may be a muscle injury as well. In that case, we have to do CPK and other things to confirm whether this is due to a liver problem or skeletal muscle problems. For example, in poliomyositis, you get markedly elevated AST, but it is associated with CPK elevation as well. In the presence of hypothyroidism, which can cause mild muscle injury, and the release of aminotransferases can occur. And also it is important to know this AST, ALT values have skewed distribution. Always it is towards high end. For example, if we say upper range of AST, ALT maybe 40, most of the results are towards the 40 side. And all the laboratories should have their own reference ranges ideally. Causes for AST, ALT, raised AST, ALT values: autoimmune hepatitis, hepatitis B, hepatitis C, drugs or toxins, ethanol, fatty liver, growths, hemodynamic disorders, iron or copper or alpha-1 antitrypsin deficiency or muscle injury. All then these can cause elevated AST, ALT values. Once you see the report of AST, ALT elevated results, we have to think of all the possibilities. And also this is very important. When we say elevated AST and ALT, we can see ranges. For example, if it is normal, it is less than 40. But in cirrhosis, usually around below 100. But if it is severe liver cirrhosis, because functioning hepatocytes are not there, it will be very, very low. Then chronic hepatitis. With chronic hepatitis, you get around like range below 300. Alcoholic hepatitis, little bit higher, maybe around 500, 800, 1000. But acute viral hepatitis, usual range is around 3000. But if it is a toxic injury or ischemic injury. For example, if a patient is going, patient present with road traffic accident with severe ischemia or shock, or after bypass surgery, sometimes patients go into shock. They end up with very high elevation of AST and ALT, and we have seen in the past COVID pandemic also, we have seen very high elevation of AST and ALT levels because of combination of viral damage as well as ischemic injury. By looking at elevated range, we can guess what the patient is having. Then alcohol and ALT, AST. In acute alcoholic hepatitis, serum AST level is less than 500. The serum ALT value is less than 300 upper limit most of the time. AST-ALT ratio more than 1 in 90% of patients and is usually more than 2. In the absence of alcohol intake, an increased AST-ALT ratio is often found in patients with cirrhosis. But these ratios, we don't always go by these ratios. Alkaline phosphatase. Alkaline phosphatase is another very important enzyme in our liver profile, produced by the cells of biliary caniculi, catalyzes the hydrolysis of phosphoric and monoesters, but it is it is a isoenzyme. Because of that, it is present encoded by a single gene, and it is present in various places like bone, liver, intestine, kidney, placenta. Therefore, by looking at elevated alkaline phosphatase alone, we can't say patient is having liver pathology. Maybe patient is having vitamin D deficiency, or maybe a fracture, healing fracture, maybe a kidney problem, maybe patient is a pregnant patient, because placenta also giving rise to elevated alkaline phosphatase. So we have to think of the clinical situation. Causes for increased serum alkaline phosphatase: intrahepatic and posthepatic cholestasis, increase in biliary obstruction and space occupying lesions in liver. It is very common. Jaundice and more than 2.5 upper limit normal elevation, cholestatic jaundice. But if the alkaline phosphatase is thousands or 6 times upper limit, 6 times of the upper limit, is found in diffuse infiltrative diseases of the liver, such as infiltrating tumors and fungal infections. And also it is present in elevated in bone diseases like Paget's, which is not very common in Sri Lanka, but tumors, hyperparathyroidism, osteomalacia or rickets, renal osteodystrophy, pregnancy, and some tumors can synthesize directly. Gamma GT catalyzes the transfer of gamma glutamyl groups from a natural or synthetic peptide or peptide-like substrate to a acceptor, which is usually a dipeptide. Causes of increased serum levels of gamma GT, liver diseases, and it is very important to know this is an inducible enzyme. So alcohol, like drugs like phenytoin, barbiturate, rifampicin, can cause elevation of gamma GT without any of the problems, like any of the liver disease, because it is inducible enzyme. If there's, therefore, before interpreting, we have to take the patient's drug history carefully before interpreting, especially if only the gamma GT is elevated. Only gamma GT elevation, common cause is alcoholics. They get on and off alcohol, because alcohol causes elevation of gamma GT, but as they are not taking regularly, there won't be much elevation of AST and other things, but gamma GT will be raised, same as if the patient is on drugs. Now, I have some cases, some reports actually. Now, you can see this patient's bilirubin. Maybe total bilirubin is total bilirubin 353 and direct bilirubin is not much high. That means patient is having indirect hyperbilirubinemia with elevated total bilirubin. This is a report from a neonate who is having physiological jaundice because liver is immature. Liver cannot handle all unconjugated bilirubin or bilirubin coming to the liver. This is a common in physiological jaundice. And this one, age is not mentioned, but very important thing is AST and ALT is markedly elevated, but albumin not that low, but little bit low, and bilirubin not that high, and gamma GT is elevated. This is some kind of acute hepatitis. It is common in viral hepatitis, but with time, bilirubin is expected to raise, but this is not much elevated, only marginally elevated. With the, if the infection is going on and liver is getting enlarged, you get high elevation of both total and direct bilirubin, or unconjugated and conjugated bilirubin, both fractions. This one, this patient's total bilirubin is 266 and direct bilirubin 203. So this patient, and also important thing is gamma GT is very high and alkaline phosphatase is high. So and albumin is not that low, it is normal. So this patient's total bilirubin high with a higher direct fraction with markedly elevated gamma GT and alkaline phosphatase. This is probably due to a obstructive jaundice. So in this case, we have to do ultrasound scan abdomen and think of biliary polylithiasis like things. Then I think this is the last one. This patient's total bilirubin borderline high, gamma GT not that high, and important finding is albumin is 2.8 and marginally elevated, like mildly elevated ALT AST with borderline elevated total bilirubin, and globulin fraction is very high with very high. So this patient probably is having chronic hepatitis leading to cirrhosis because synthetic capacity is impaired, therefore albumin is low. But in this case also, we have to do a urine albumin level and confirm that patient is not losing urine, protein in urine. And this one, AST-ALT normal, but bilirubin little bit high. Maybe this patient is recovering from hepatitis. I think, but as I think you got some knowledge on liver enzyme parameters, liver profile parameters. What you have to do is, when you are working in the laboratory, go through everyday reports and just call, just imagine what can happen to this patient, and just call the ward and reconfirm whether this is, your diagnosis is correct. And by that, you can build up your own ability of interpreting liver function test, which will be helpful in future working in future laboratories. Thank you very much.
Thank you, sir. So if there's any questions, you can ask now. So in the absence of any questions, let me invite to our next speaker. She's Dr. S.I. Majeta, Consultant Chemical Pathologist from Teaching Hospital Batticlaw, to deliver her speech on interpretation of thyroid profile and endocrine testing.
Thank you very much. I am thanking the college president, Dr. Kisali, and the council members for doing such a wonderful workshop for the MOs, and thanking again for me in my team as a resource person in this workshop. So our topic is interpretation of thyroid profile and common endocrine test. It's a vast topic. I will try to finish within a given time. So when you take a thyroid function test, it's a commonly ordered test by the clinicians. So interpret the thyroid function test. We have to understand about the hypothalamic pituitary thyroid axis. It's a very important and key for the interpretation of thyroid functions. If you understand the thyroid hormone axis, you can easily interpret the report as well. So when you take hypothalamic pituitary thyroid axis, the hypothalamus secretes TRH that will act on the pituitary, and the pituitary release the TSH. TSH will act on the thyroid gland. So thyroid gland will release T4 and T3. This T4 and T3 will act on the pituitary and hypothalamus and inhibit the secretion from those areas. So if there is any problem in the end gland, that means thyroid gland, there will be a disturbance, or the pathway will get stimulated or inhibited. If you take the thyroid gland, if there is a hypofunction, there will be low T4 and T3, there will be a diminished inhibition to this pituitary and hypothalamus. So the TSH and TRH will get stimulated and there will be high values. If it is a hyperfunction of the thyroid, there will be a high T4 and T3. There will be increased inhibition on those two organs. Then there will be a diminished TSH and TRH. Normally, we are not measuring the TRH in the blood as a routine test. So the thyroid function test, we look at the TSH and T3 and T4. The term TFT includes TSH, free T4 and T3. When you look at the thyroid function test, you have to concern on three elements, that is a reference range and the units and whether it is done in the same lab or different lab, because the reference ranges are changes from adult to children and pregnant women. Sometimes the different reference ranges are varies between labs, and the units also varies between labs. The important points you have to remember when you see the thyroid function test, the thyroid gland release more T4 than T3. Most of the T3s are converted from the T4 into T3 in the peripheral circulation. If you take a thyroid gland, the thyroxine is normally carried in the blood with the binding protein that's called thyroxine binding globulin. So many are bounded to the globulin and few are released in the circulation as free form. So that is 1% of total T4. So in this, because of these things, the free T3 is less relevant compared to the free T4. So except in one situation like T3 thyrotoxicosis, where the free T4 will be normal with suppressed TSH. So when you change the thyroxine dose after initiating the treatment, you have to wait a couple of weeks to see the response, because the half-life of the thyroxine is around 1 week. So we have to wait a couple of weeks to see the response or to change the dose. When you take a hypothyroidism, hypothyroidism, when you take, we can divide into primary, secondary, and subclinical. The primary hypothyroidism is the commonest one, and it involves in the thyroid gland, problem in the thyroid gland. So there will be a hypofunction of the thyroid gland. There will be a low T3 and T4. Because of this low T3 and T4, there will be a diminished inhibition on pituitary and the hypothalamus. So feedback inhibition will be reduced. So in turn, there will be a increased secretion of TSH. So ultimately, you will end up with the low T4 and T3 with the raised TSH. If you see this report from our lab, we got from the ward patient with the hypothyroidism, you can see the T4, previously it was free T4 is less than 0.8 and there's a TSH is very high. So they have started treatment. Now the T4 come up little bit up, but below the normal range. Still the TSH is high. Here you can see with the treatment, if it's a T4 is increasing, the TSH should come to reduce from 100 to low. But here not reduce, still in the same value. That means you have to think about here whether the patient is complying the treatment. Compliance. I think here there's a poor compliance because still the TSH is in the higher side. So before coming to the clinic or to the ward, patient is taking the thyroxine. That can show a normal, closer to normal value or from previous value to higher than the previous value, still but the TSH is in a higher side. So we have to think about the poor compliance here. So in secondary hypothyroidism, it's a secondary means no problem in the thyroid gland, problem in the pituitary or hypothalamus. So, but the secretion is reduced. That means TSH reduced. Because of that reduced TSH, there will be a low free T4 and T3. But you can't always expect the low TSH and low T4 and T3. Sometimes there will be a normal T4 and T3 with the normal TSH. That will be in a normal means it's not a midway, but is lower side of the normal. So when you take this patient is having a migraine since they 13 years old, now the 29 years, but they have some suspicious of any problem in the pituitary. These previous values, the TSH is below normal, marginally low. The T4 is also normal, but it is a lower range. So they are also having a suspicious of some problem in the pituitary. Second time, they have ordered all the anterior pituitary hormones. Yeah, they didn't include the cortisol. We include the cortisol also in this patient. We got a report like this. If you see, there's a T4 and TSH are all low side, the FSHL is low, and the cortisol is normal side, but you can see a high value for prolactin. This is suspicious of prolactinoma. So there could be a prolactin secreting tumor. This tumor is suppressing other tissues, rest of the tissues in the pituitary. So they are waiting for the CT brain. So once the CT brain done, we can confirm the diagnosis. So it's a secondary cause. Because of this prolactinoma, these other things are suppressed. So it's a secondary hypothyroidism. So other entity called the subclinical hypothyroidism. In subclinical hypothyroidism, there will be a raised TSH but normal T4. So if you take this case, it's a multinodular ovoid patient. You see the T4 is a low side, but normal. The TSH is high. So here normal T4 with the high TSH, we call it as a subclinical hypothyroidism. In subclinical hypothyroidism, whether to treat or not to treat, decided by some factors. One is, if it is a TSH more than 10, you have to start treatment. Or if it is a less than 10, patient is clinically symptomatic, you have to start. Or patient with the low 10 TSH, means that is less than 10 with positive thyroid antibodies, TPO antibody, thyroid peroxidase or antithyroglobulin antibody positive, you have to start. Otherwise, the patient can go into a overt primary hypothyroidism. This T4 will further reduce and TSH will further increase in the future. So likewise, the hyperthyroidism. Hyperthyroidism, again, we can divide into three: primary, secondary, and subclinical. If you take as a primary hyperthyroidism problem in the thyroid gland, so there will be increased amount of T4 and T3. So we can, because of this high value, the T3 and T4, there will be an increased inhibition to the pituitary and hypothalamus. There will be a suppressed TSH. Ultimately, you get raised T3 and T4 with a low TSH.
there's a small technical error in connecting. Please be there with us. We can see you, madam.
I think the video sharing side by side mode,
Yeah, it's okay.
I couldn't do it.
No, it's all right, madam. We can continue like this. If you can share your screen.
Switch off the video.
Alright, madam. Now, like, we can see the side by side mode.
Side by side mode, can you see?
Yeah, I can see you. Yes.
Side by side mode?
Is it? Yeah, it is.
It's there now.
It's there.
Oh, okay. Okay, thank you. So sorry for the disturbance. So in this primary hyperthyroidism, you can see a report. It's a patient diagnosed for a patient with hyperthyroidism. Previously, the free T4 is more than 90 and TSH is less than 0.015. So they have started the treatment carbimazole. After that, the T4 is coming down for 50 and still the TSH is in the suppressed level, because you can't expect the TSH is immediately come to a normal side, because it's a long-term suppression, will take time. It can take sometime in 6 months to 1 year. We have a lot of experience with this, but you can go with the free T4 level in this patient, whether it's coming down or not. So if you take then another entity called secondary hyperthyroidism, so secondary hypothyroidism involves stimulations of thyroid gland. If its name itself saying a secondary, there is no problem in the thyroid gland, the problem in the higher centers, and therefore it's high TSH from the pituitary. So that is high TSH in turn will cause a raised T4 and T3. So this is a case, 56-year-old male patient presented with the features of hyperthyroidism. When they do a thyroid profile, you can see all TSH, T3 and free T4 on the higher side with the negative thyroid antibody, anti-TPO and anti-TG antibody. So ultimately patient diagnosed as having a TSH secreting pituitary tumor. So the other entity called subclinical hyperthyroidism. Here the free T4 and T3 are in the normal range, but the TSH is in a suppressed levels, low or undetectable. So here is a case of subclinical hypothyroidism. Patient started on carbimazole and propranolol. Before starting, the values are TSH is in the very suppressed level with the higher side T4. With the treatment, the T4 come to a low normal side, still the TSH is suppressed level. So low T4, here also low T4 with the suppressed TSH. The normal T4, sorry. So other thing which is very important to know about the thyroid cancers and the treatment for the thyroid cancers and the thyroid function test during the management of the thyroid cancer patients. So thyroid cancers can originate from the follicle or from the medulla. If you originated from the follicle, means that is we are calling differentiated thyroid cancer. It could be a follicular carcinoma or papillary carcinoma. You know that the medullary carcinoma is originated from the parafollicular C cells in the medulla. Normally, the normal physiology, TSH is necessary for the functions and the growth and proliferation of the follicle of the thyroid. The TSH stimulates the thyroid follicles and the proliferation of the thyroid follicles. In the treatment process of thyroid cancer, they will do a total thyroidectomy for both, for the differentiated thyroid cancer and the medullary thyroid cancer. We have to replace the patient with the thyroxine. For the thyroid cancers, that means we are normally calling a thyroid cancers, a differentiated thyroid cancer, we have to suppress the TSH level, because the TSH, if it is in a normal level after thyroidectomy, it can stimulate the thyroid tissue which is left after the remnant tissue left after the surgery, or is there any ectopic thyroid tissues in the body, or is a minute metastasis occurred without our knowledge. It can be lodged somewhere, and that can be get stimulation from the TSH. So we have to give a suppressive dose of thyroxine for the differentiated thyroid cancer. So the TSH should be in a suppressed level, that means less than 0.1. There are different categories of suppression depending on the risk of the thyroid cancers. In the medullary thyroid carcinoma, we don't need to give a suppressive dose of thyroxine, because there is no such a function. The stimulation will cause any problem to the patient by the TSH. So we can give a replacement dose. That means we can keep the TSH in the normal values. So if you take this patient, TSH and T4 values, so thyroid carcinoma patient, you can see the T4 in the normal range, but it can go up to the high level. But the main target is to keep the TSH in a suppressed level. So other entity called thyroid hormone resistant. Here the thyroid hormone resistant, there's a receptors from the peripheral tissues as well as in the pituitary for the thyroxine hormone. So that receptor is getting some mutation and causing problem. So because of that mutation, the thyroxine cannot be taken up by the peripheral tissue. There will be an increased amount in the blood. So at the same time, this thyroxine cannot inhibit the pituitary. There is some mutational change in that receptors also. So there can be a high T4 TSH in the peripheral circulation with normal or high TSH. So another entity called is a sick euthyroid syndrome or non-thyroidal illnesses, or euthyroid sick syndrome. That is, it's not a problem with the thyroid gland. It is a problem due to illness. These are some illnesses can cause the sick euthyroid syndrome: the starvation, calorie deprivation, acute febrile illness, MI, acute respiratory failure, renal failure, surgery, and cirrhosis, so on. Then this infection or inflammation can release a cytokine. That cytokine causes some derangement in the thyroid functions. The most common hormonal pattern in sick euthyroid syndrome is a low T3 and free T3 levels with the normal T4 and TSH, but there will be high reverse T3. But this is not always true. There's several changes can happen. It is depend on the severity of the illness, whether it's a mild disease or moderate or severe illnesses. Sometimes it can change with the recovery phase of the illnesses. So if you take this graph, you can see this is a illness categorized to mild, moderate, severe. There is a T4 and reverse T3 and free T4, TSH, all are illustrated as a graph. So here you can see recovery phases. The TSH is high, but T4, T3 coming to the normal level. But here the severe condition, if you see, TSH also lower side, free T3, free T4 also, total T4 and T3 also in the lower side, but reverse T3 throughout, keeping in the upper side. Early. So depending on the severity of the disease and the recovery phase of the disease, the abnormality can vary. So if you take this box chart, here the low TSH, the normal, here they have shown a non-thyroid. You can see here the non-thyroid illnesses. Here the recovery phase non-thyroid illnesses. Here you can see in the low TSH with normal T4, there is a cause for non-thyroid illness. This is can caused by the non-thyroid illness. And here if you take it, this box with the low T4 and T3 or low TSH or normal TSH, here with the low T4 and T3. If you take this, it's a high TSH with normal free T4 and T3, that is a recovery phase of thyroid illness. The most important thing is here, when the patient is having some other illness other than the thyroid problem, during the illnesses, don't order thyroid function test because it can give a bizarre result, so you can't fit into any abnormality. So you have to skip that period and do in patient get recovered from the acute illnesses. So if you take, this is an algorithmic chart. You can do a TSH when you do first TSH, if it is a high, then you can do a free T4. Free T4 is increased means this is a secondary hyperthyroidism. The T4 is increased, TSH also increased. If it is a T4 is normal or reduced, so because we can reduce T4 can increase the TSH, that is primary hypothyroidism, you can give a treatment. If it is a free T4 is a normal, it is a subclinical hypothyroidism. Depending on the situation, I already explained, you can go for a treatment. If the TSH is reduced, again you do the free T4. If it is increased, that's primary hyperthyroidism. Primary hyperthyroidism can be toxic nodules or Graves' disease or thyroiditis. So in that case, you have to do an isotope scan. If it is a uptake increase, that's a Graves' disease. If it's a hot nodule, you can think about the toxic goiter. If it is uptake is reduced, could be a thyroiditis. If the free T4 is reduced, then you can do a reverse T3, but normally in Sri Lanka, in the government sector, I don't think anybody is doing the reverse T3, but it's for the completeness of this understanding of this thyroid abnormality, we can go by this. Reverse T3 will be increased. And if it is increased, I have shown that in the previous non-thyroid illness graph, this is reverse T3 is increased, then go for the non-thyroidal illness. If it is reduced, then with the reduced TSH, reduced T4, that's a secondary hypothyroidism. You can go for a brain CT to diagnose any abnormalities. If it is free T4 is normal, with the reduced TSH, I have already told in the very first slides, so there's a T3 toxicosis. So with the normal T4 with the suppressed TSH, the reason could be a T3, high T3 secreted by the T3 toxicosis. So then you have to do the free T3. If it is normal, then you are low TSH, normal T4, that is subclinical hyperthyroidism. If it is T3 increase, then T3 thyrotoxicity, you can start the treatment. If it is a normal TSH, here they have told to stop this evaluation. It's not like that. You have to, if you are having a suspicious with the normal TSH, a strong suspicious of thyroid abnormality, you can do a free T4. Since free T4 low, you can think about the secondary hypothyroidism. If it is a high free T4, it's a thyroid hormone resistant. So these are the thyroid abnormalities and the interpretations, how we can interpret the thyroid disorders. So I think you have got some idea about the interpretation of thyroid disorders. I have given others topic about some important endocrine tests. So I will go for that. Before going to that topic, we have to understand about the dynamic function test, because most of the times hormones are not in a normal pattern of secretions. So sometimes it's maybe normal or low or high during the time of during the take the whole day, the changes are occurring within the 24 hours. So simple basal values are not sufficient to diagnose hypo or hyperfunction. So normally in the endocrine functions, we are doing a dynamic function test. So there are two types of dynamic function test: stimulation test and suppression test. The stimulation tests are normally done to check whether the glands is secreting whenever we give the stimulation. That means hypofunction. If you are suspecting hypofunctions of that gland, you have to give a stimulations, whether with the stimulation it is secreting in enough amount of hormones. In that case, we can exclude. The same way for the hyperfunction, to check the hyperfunction, we have to suppress and see. We have to give a suppressant to the gland and see whether it is suppressing for the stimuli. So with this one, I am going to touch not all the dynamic function tests. The main one is the adrenal gland problems, and it's the growth hormone problems. So when you take adrenal hormones like the hypothalamic pituitary thyroid axis, here also we have to think about the axis, the hypothalamus, pituitary and adrenal axis. You know that TRH is released from the hypothalamus and stimulate the anterior pituitary. The anterior pituitary release the ACTH. It will stimulate the adrenal cortex and release the cortisol. So this cortisol can the same way inhibit the anterior pituitary and the hypothalamus to reduce the secretion. So if we take the thyroid, hypothalamus pituitary adrenal axis, if the problem in the adrenal gland, that is a primary cause, there will be a low cortisol, then increase the stimulation of TSH and CRH. If it's a problem in the pituitary, there will be low ACTH, then low cortisol, but the CRH will be increased. If the problem in the hypothalamus, the TRH, CRH will be less, and there will be low ACTH due to this, and there's low cortisol. All the levels will be low. So if it's a cortisol deficiency, you know that deficiency means you have to give a stimulant and see what is the stimulant for the cortisol secretion. It's the ACTH. But how can we give the ACTH? We can use synthetic ACTH, that is the synectin. So there are several tests, short synectin and long synectin test, and we can go by these tests. So if you take a short synectin test, it's a simple test. If the synectin is available, you can do it. With this synectin, we can just measure the cortisol. For this test, you have to cannulate the patient in the morning. Before cannulating the patient, you have to take a basal sample at 9 o'clock for the cortisol. After that, you give the synectin 250 microgram IM slow IV, and after that, at 30 minutes and 60 minutes, you have to take 2 samples for the cortisol. For this test, if patient is already on steroid therapy, such as hydrocortisone or prednisolone, we have to stop that. For the hydrocortisone, discontinued before 24 hours. If it is not possible, at least for 12 hours. If it's a prednisolone, you have to discontinue for at least 3 days. If you think the patient cannot be cope up without the steroids, you can give as a replacement, as a dexamethasone. So you take the basal sample, then given the ACTH, after that 30 minutes and 60 minutes, 2 samples, altogether 3 samples. Then how to interpret this? If there is a 200 nanomole per liter increment from the basal value to 30 minutes or 60 minutes, or if it's a highest value is reached more than 550 nanomole per liter, you can tell there is no adrenal problem, adrenal insufficiency. Because when you give the stimuli, patient is secreting enough cortisol. So here you can see we had a patient with a low cortisol, then we have done this test. The basal cortisol was 14.9. We have, after given 30 minutes and 60 minutes levels are like this. There is no either 200 increment or not reached up to 550. There is a insufficiency. If you want to further confirm whether adrenal problem or higher problem, you have to go for a long synectin test or some other test. See, this is the other patient. Here also low cortisol, but here 30 minutes and 60 minutes, there is an increment from basal to one of these two values. There is a more than 200 in, but this patient does not reach to 550 nanomole. Here we have to go with the clinical history, whether it's a truly a patient is having a adrenal insufficiency. Depending on the clinical condition, with the coordinating with the endocrinologist, we can decide. So the long synectin test here is a longer synectin test, means another modified version of short synectin. Here we are giving the 250 microgram synectin for 3 days and the last dose for 8-hour infusion. It's a longer period we are giving. The interpretation is also here same. If it is reached 550 nanomole, there is no problem. If there is low or little or no increase of cortisol on successive days, we can tell this patient is having a primary adrenal failure. If it is a progressive staircase increment throughout the successive days, say we can tell there is a problem in the pituitary or hypothalamus, or patient is having externally taking a corticosteroids long time, that is suppressing the ACTH level and giving the problem. For this long synectin test is nowadays nobody is practicing because the availability and reliability of the ACTH assays are available in a tertiary care centers. So with the low cortisol, with the same time you can, with the cortisol, you can do the ACTH assay and find out the cause. So here we can see a report. Here you can see is low cortisol. The other anterior pituitary hormones also is with the patient is 67 years, low side. Here also T4 and T3 low side with the normal TSH. So we done a testosterone on this patient, it is a low. So with this low of testosterone, if you see it's a problem in the testis, the TFSH should increase, but not increase. So the low TSH could be due to this low FSH and LH. So here low FSH and LH, this is a normal, but for this is for low T4 is a normal, TSH is not. So not a problem in the thyroid, a problem in the pituitary could be here the low cortisol. So we have done ACTH. ACTH is upper normal. Do we think this ACTH is normal for this patient? Because it's not normal. Because if it is a normal, there should be a normal cortisol. The patient doesn't have the normal cortisol. That means problem somewhere in the pituitary. If it is a problem in the adrenal, if it's a low cortisol due to adrenal problem, the ACTH should increase. But here is a upper normal, so there is a problem in the pituitary. Ultimately, this patient diagnosed as having a pituitary adenoma. It's a non-secretory adenoma. That is mechanical suppression given by that adenoma, mechanical suppression to the other tissues in the pituitary, causing the hypopituitarism. So it's a cortisol excess. Excess is due to Cushing syndrome. Cushing syndrome could be ACTH dependent or independent. So we can go for some test. Cortisol excess. We have to suppressancy. That is there are several tests. We can go by one by one. Said or overnight dexamethasone suppressant test is you are giving a midnight 1 milligram of dexamethasone, and morning you are taking a basal value, the blood for the cortisol. If it is suppressed less than 50 nanomole per liter, you can say there is no or excess secretion of cortisol. So, but some other condition like this can cause not suppressed cortisol. So with this one, we can go for a low dose dexamethasone suppressant test. So in the overnight dexamethasone suppressant test, this patient is suspicious of cortisol excess. With this one, we have done an overnight dexamethasone suppressant test. Here you can see this, there is no suppressant. It should be less than 50 here. So we can go for a low dose dexamethasone test. In the low dose dexamethasone set, still with the basal value this, but it's not suppressed to less than 50 nanomole. So it's unsuppressed. So with this patient, we have done a ACTH. With the ACT availability of ACTH, we are not going for the other test like high dose dexamethasone. The ACTH is reduced. So you can think about now the feedback mechanism of this adrenal axis. High cortisol will suppress from the adrenal gland will suppress the ACTH pituitary. So here reduced ACTH. So the patient diagnosed as a left adrenal adenoma is a ACTH disease. After adrenalectomy, you can see the value of this patient is come to a normal low level. This is another patient referred from the Kalmunen-based hospital with the hypertension and the hyperpigmentation. They have done a serum electrolyte. It is more favor of high cortisol. So high cortisol could be adrenal or pituitary. Here more favor of pituitary due to ACTH because of the hyperpigmentation. Hyperpigmentation caused by the high ACTH. So we have gone straight away without wasting time because patient is in the ICU. So we have done all the anti-pituitary hormones. You can see the reports. If it's a very high cortisol, if it's adrenal problem, ACTH should suppress, but here not suppressed, it's increased. That's the culprit is the ACTH from the pituitary. So it's ultimately diagnosed as a Cushing disease. That means pituitary Cushing's. That is ACTH dependent. You can see all the levels are the hormones in the pituitary reduced, TSH reduced because of the T4 reduced, LHFSH reduced, prolactin reduced. The growth hormone, though it's a normal range, when you see the IGF-1 level is very low. So it's that tumor is causing a hypopituitarism with the high cortisol. It's a growth hormone disorder. So the same axis. I don't waste time here because we are running out of sort of time. So I will go through. If it is a growth hormone excess, if it is in adult, acromegaly. If it is in children before fusion of the epiphyseal plate, that is a gigantism. If it is a low cortisol, we are calling it dwarfism, pituitary dwarfism. So for the excess, growth hormone excess, you know that dynamic function test, the growth hormone is a diabetogenic hormone. When the blood sugar is reduced, it will secrete it. If it's a blood glucose increase, it will get suppressed. So we have to make in a suspicious of cortisol excess, we have to give a condition for the to suppress that hormone. So we are giving a condition that is increasing the glucose by giving an oral glucose, like oral glucose test for the diabetic mellitus. So here you have take a basal sample. After that, giving the glucose and taking 30 minutes, 60 minutes, 90 minutes, 120 minutes sample for the glucose and GH. If it is a normal person with the high glucose level, the GH hormone should be suppressed to a less than 1 nanogram per ml. If it is not so, there's a growth hormone excess. Not only due to the growth hormone problem, some other condition also like this also can cause a non-suppression. So we have to investigate further. This patient, we have done oral glucose tolerance test. We have given basal, taken the basal value. After that, the time value with this growth hormone and the glucose, you can see the maximum glucose is 9.4. With this maximum glucose, it should be suppressed, less than, come to now less than 1 nanogram per milliliter. It doesn't come. That means the patient having a problem in the cortisol, the growth hormone excess. So this is investigation for growth hormone deficiency. Deficiency, you know, you have to make a stimulant to the patient that can increase the secretion. What is the stimulant? Hypoglycemia. There are several tests to make a hypoglycemic in the blood. So we are going for a glucagon stimulation test. You can ask why glucagon action of the glucagon is increasing the glucose in the blood. But initially it will increase with the time, 1.5 hour, 2 hours time, it will cause a hypoglycemia. So that hypoglycemia is enough to produce a growth hormone. So we are checking that one by doing a glucagon stimulation test. So this is the report with the glucagon stimulation test. You can take a sample before giving basal. This is the values for the growth hormone, cortisol and glucose. After that, you give the glucagon and serial samples are taken. You can see here is the maximum hypoglycemia occurred. With this maximum hypoglycemia, if the patient is normal, his GH hormone should be increased. So here you can see what is the cutoff for normal response for the glucose stimulation. This is the normal response is more than 7. That is far enough for us to exclude the patient with no, we can tell safely, we can tell that patient doesn't have any problem with the growth hormone deficiency. So here we reached 9. So we exclude this patient doesn't have a growth hormone deficiency. But if you do a basal single reading, see here, so low values. Here low values. If it is in the this area also low values, but we can't go by this one. With the maximum hypoglycemic situation, how the pituitary functions. This is the value we have to take. So that's all. So thank you very much for listening. Sorry for the, I couldn't finish the presentation within the target time. So I think the MOS got some ideas about the function test and the other some endocrine test. If you have any question, I am very happy to answer. Thank you very much for listening my lecture.
Thank you, madam.
Thank you, madam.
As we are running out of time, madam, shall we continue with the rest of the workshop? Okay. Right. Now let me invite Dr. Iresha Jasinde, consultant chemical pathologist of Lady Vidya Hospital, Colombo, to deliver a speech on calculations in chemical pathology.
Oh, Saraji, can you hear me?
Yes, madam. We can.
Yeah, it's another coincidence, Saraji. You are always there to introduce me. Yeah? Thank you so much for your kind introduction.
I'm privileged to do so, madam.
Yeah. Yeah. First of all, I would like to thank Dr. Kisali, our president, for giving this opportunity to discuss an untouched area in chemical pathology. What I assume this is an essential aspect in validating reports by the MOs. Yeah. So can you see my screen, Saraji?
Yes, madam, we can see you.
That's all, no? Right. So what's it? Your full screen? Yeah.
Yes, madam. Yes.
What shall I do?
We can see clearly, madam. Yeah.
So shall I go on?
Yeah, you can continue.
Right. So we'll discuss some calculations in clinical chemistry, but after all the other eminent speakers' speeches, I wonder whether they are keen enough to listen the calculations. Of course, I have to continue. Right. Puta, come. It's not working. Oh, it's not moving. What's wrong with it?
We can see the slides, madam.
But they are not.
Right, yes, it's clear.
Okay, right, okay. Right. So I thought of telling only few calculations that are needed to validate reports while going through blood and urine reports. First of all, we will see what corrected calcium is. There's a scenario, a 45-year-old woman with backache, and the clinician wonders whether this is hyperparathyroidism. So if you see this test, this calcium, of course, you know, this is measured in the laboratory. Albumin, again, a measured one, and phosphate. So by looking at this, this patient doesn't seem to have hypercalcemia with only calcium results. So therefore, there's another parameter called corrected calcium, which is a derived factor. So what is that? How do you calculate the corrected calcium? There are two formulas. I don't know why it is going so fast. So measured calcium in milligrams, there's one formula here. And in millimoles, there's another formula. I think you have to know this by heart. Right, it depends on the albumin level in albumin gram percent in milligrams and grams per liter in millimoles. So why do we do that? We want to get the Y40 and 4 values are taken. That is the average serum albumin level. Right. So actual calculation is this there. It is measured calcium 40, this is for millimoles per liter, 40 minus albumin divided by 40. When you take this 1/40 out, it is roughly 0.025. So that's why we take it as 0.024 as the factor for corrected calcium in millimoles per liter. So we'll apply the values to the formula and see for your convenience. Do this as a most when you go to the reports, 35, and the difference is +5. So you get a 1.1 value. That's why it's became 2.5 became 2.6. See, when albumin level is low, the corrected calcium becomes high. So similarly, we'll go to another one. When a patient is dehydrated, you get high albumin. So similarly, when you apply it here, it's a minus factor. So therefore 0.1 is reduced. So when albumin is high, the corrected calcium tends to be less than that of the measured calcium. So here it is very important. Sometimes we might miss patients in the borderline range, and we might, if the albumin level is low, we might not say this hyperpara unless you have ionized calcium to do. Right. The second commonest calculation we use in the laboratory is when you go through a lipid profile. It's a 40-year-old male who has gone for the medical checkup, and these are the values he was given. Total cholesterol. All these three are here analyzed by the autoanalyzer or manually, and this is the derived factor. So we see how it comes. It's called a Friedwald equation, where total cholesterol is the addition of cholesterol in HDL, cholesterol in VLDL, and cholesterol in LDL. So therefore, LDL cholesterol, when it is come to the calculation part, is a difference between total cholesterol and the cholesterol in the other two. But this is measured and this is measured in the lab, but VLDL is not measured. Again, it is derived. So if VLDL in milligrams, the factor is 5 to divide triglycerides is divided by 5. And if it is in millimoles, the factor is 2.2. But there are some limitations. If triglycerides are less than 400 milligram percent or in 4.5 millimoles per liter, this formula is not applicable. Therefore, you have to get the levels analyzed by the analyzer. So we'll apply this, all the values to the formula and see the total cholesterol 245, HDL 55, and as I told you earlier, if it is in milligram percent, divided by 5 the triglyceride value, then the sum of these two is this, and when you subtract it from 245, your value comes nicely. So it's better if you can go through all for when you do a lipid profile hereafter, calculate and see whether the lab has given the correct report. So it's good for the dementia also do some calculations while validating the reports. Don't accept what is being given to you. Go through all the values, the units, be familiar with those. So there's another interesting calculation called osmolarity. And there are two terms you have to know. One is osmolality, which is measured if you have an osmometer in the lab. And osmolarity is what is calculated. In both situations, we estimate the osmolar concentrations in either plasma or serum. But the units are different. This is for the weight, kilogram of solvent, your plasma or serum. The other one is per liter. So the units for osmolarity or your calculated one is liter, millimoles per liter. For your osmolality, it is the SI unit is millimoles per kg, and sometimes this unit is also widely used. So why do you want to do these tests? Right? The formula to do calculate osmolarity is to consider sodium levels in the blood, urea and glucose, and sodium is doubled. And if urea is in milligrams, because urea molecular weight is 60, so millimoles per liter and deciliter factor, so it is divided by 6. 60, not 60, it's 6. Glucose molecular weight is 180, so therefore the factor is 18. So some labs still use milligram percent to issue reports. So in those laboratories, they have to use this formula. So somebody might question why sodium is double. That is because chloride is also the negative ion is there to account for that. So that is why it is double. Then why in certain situations you want to know there's a osmolar gap. That is your measured ones in our body also, the calculator, there's a difference. And difference can go up to, in certain books, say 10 or 15, it doesn't matter. But if it's very high, then you have to think whether there is some unmeasured osmotically active substance which has not been taken into the calculation, like your methanol, ethanol, sometimes in neurosurgical units, mannitol. So there you see a difference. So just don't go through this slides. Please be active now, be practical by doing calculations and going to see patients. Even the medical officer level, don't think the registrars are the only people who should go through the reports. You also can learn a lot by validating reports. It's very interesting, and liaise with the clinicians, be more active. Right, there's another thing called anion gap. Anion gap is the measured cations and the unmeasured anions difference. And it indirectly says it's the difference between your unmeasured anions and unmeasured cations. So this part is very important. So if we usually take the most important cations, so sodium and potassium, and anions are chloride bicarb. If this is high, that indicates your unmeasured anions are high, not the sodium and potassiums are high. Or chloride bicarbs are low, but your unmeasured anions like lactate, in diabetic patients, beta hydroxybutyrate, acetoacetate, those are anions. Even in renal failure, phosphates, sulfates, they are not filtered by the kidney. So those unmeasured anions accumulate. So that's why you get a high anion gap, not because your sodium and potassium are high, so the difference is high. Okay. So we go to a report. This is our own patient, a 3-year-old child who came in unresponsive state. See, this anion gap is very important in the presence of acidosis. This baby is having severe acidosis with a bicarb of 10. Obviously, there is severe acidosis. So its electrolyte values are these. And if you apply this to this formula, sodium, potassium is come from 153, and with these T 127. So the difference is 26. It's a very high anion gap. So if a child with acidosis, if the anion gap is high, so it indicates it's not really diabetes, because children usually don't go into diabetes, maybe very rarely, but we have to consider whether this child is having some other rare diseases. So the urine for ketone body should be performed. So this is also, it's true that you won't see the chloride, the bicarb value unless you get a referral. But if you see some sort of very high values in a patient who is dehydrated, you can call the ward and get down the BHT and go through it and apply your values to the formulas and calculate it. Isn't it really interesting to see find a patient with high and metabolic acidosis with a different diagnosis, not always renal failure, diabetes, to find out propionic acidemia, isovaleric acidemia. So like that, you must try to explore the whole hospital. So MOs are not, I think they are not supposed to sit in the lab and go through the reports. They also can go out with the clinicians, be more active. So this, of course, EGFR calculation, everybody knows because there are formulas in the internet. So I'm not going to touch all. So if the CKD-AP, there's a formula which can be used for both normal and abnormal GFR, patients with abnormal and abnormal GFR. MDRD is only for the CKDs. And for our children, there's a revised Shaw's formula. I wonder whether our clinicians do apply this. They have changed the factors from 4.45 to 0.55 to another one. Children, of course, they are not that lucky enough, but adults, of course, there are so many formulas to calculate their GFR without collecting 24 urine samples. So I thought of touching this 24 urine samples because as the doctors in the laboratory, they must know how to check whether the collection is adequate or not. So this is checked by analyzing urine for creatinine, because creatinine is relatively stable because our muscle mass is stable. So there are certain values given for males and females and children. These are the creatinine that they should pass for their body weight. So in our lab, we use this micromole fraction, but it doesn't matter somebody is measuring creatinine milligrams. These are the values that at least a male should pass for 14 milligrams per kilogram per day, a female less because their muscle mass is less. But children, of course, a little bit high value is going 71 because they are secreting part is there, right? So we see how we can apply it. Now this is the creatinine clearance formula. Formula should be written somewhere so the medical officers can go through when they want to refer. So the amount of creatinine in 24 urine, okay, that is volume and divided by serum creatinine into the collection time. But as MO, medical officers or registrar or whoever who is going through the reports need the height and weight, because this is a very difficult part to get from the house officers to calculate the body surface area and correct it for 1.73, the normalized body surface area. For that, we need this. Without this, we will be showing this part only, the value of this. So try to prepare your reports, history collection forms, and liaise with the medical officers in the wards to collect all those factors, right? So shall we apply this to one case? This is what we got from a child, 8.6 kilos. So for creatinine clearance, right? So usually we acidify the urine sample and the pH is 2 because it's for both calcium and creatinine clearance. The total volume is 150. Can you see 150 is not quite adequate because a child should pass at least 1 ml per kilogram per hour. So when you calculate it, when you divide by the 8.6, it's come to 0.72. So this part is quite enough to say the collection is inadequate and not to analyze the sample hereafter to save your reagents and time. So now somebody has analyzed it, and therefore we get a value of urine creatinine of this amount for that baby, for that child. So therefore we can calculate the amount of creatinine the child has passed by multiplying this amount 3573. What is this volume? 3573 from the total volume. This is the amount of creatinine the child has passed per day. And this is the norm. This is the amount he should pass. So if you can take this part only to see the adequacy, so he should pass 71 into 8.6 a day at least. And this is the maximum he should pass. So we don't want the maximum part, we want the minimum part. So he should pass at least 610 micromoles per day for his weight. But he has passed only 535. So that means it's an inadequate collection. So like that, you have to go through all the reports. Actually, the MLTs also should do this correct calculation to see whether the adequacy, because children, of course, we can use this formula and say this from this level, it is inadequate. But for adults, of course, I don't know. They can pass a vast amount of urine per day, no? So this is the ideal formula to find out by doing the creatinine calculation part. Okay. So there are spot urines we collect here, so we can't go all the spot urines. So I thought of taking two examples, ratios and the fractional excretions. Ratios, there are different ratios you do in your laboratory. Now I took this one because protein and creatinine, the different units. You see milligram percent millimoles per liter. So be familiar with these units when you validate the reports. So the final answer is milligrams to millimoles. Sometimes for calcium, you can measure in millimoles, and creatinine also same unit. So you won't get a unit for that. Unit, there's no unit, only a value, like, or you can say it is millimole to millimole, right? So this is one aspect. The other one is the fractional excretion, or you always want to tell you, don't by heart this formula, always fractional excretion of sodium, phosphate, bicarb, whatever it is, you remember this. This phosphate to creatinine ratio in urine divided by phosphate to creatinine ratio in serum, or whatever the analyte to creatinine ratio in urine is divided by the analyte to creatinine ratio in serum. So when you do it a reverse form, multiply, creatinine comes to the top and phosphate goes to the bottom. So I took all these because these are spot urines, and you always rely on the creatinine to calculate these parameters which are at the bottom. So you can see creatinine is divided by creatinine. So to do that, you have to have a good laboratory to measure creatinine. Your creatinine value should be very accurate. So you're checking the QC. The medical officers can go to the machines and check the QCs daily if they like, and nobody is blocking them. So go to the labs, go to the machines and check the QC for urine and see whether it's quite okay. Then the other thing is, think of the muscle mass. If the muscle mass is less, and obviously serum creatinine will be low and the urine creatinine will be low, and you will get unusually high ratios. So those are the points I would like to address here. If you have any questions, I'm here to answer. Thank you so much for listening, and I would like to acknowledge a few doctors who helped me, and the assistant given by the computer, two ladies, and all my medical staff and the technologists and assistant, and the college for giving me this opportunity to discuss this. Thank you.
Thank you, madam. Thank you very much for that very informative lecture. And it's very useful since we lack in calculations most of the time.
Yeah,
so,
true.
Yeah, I hope we can take one or two questions if the participants have.
I think participants should go through the report show now.
Yes, definitely.
At least to calculate their lipid profiles, LDL.
Yeah.
Mm.
It seems like there are no questions, madam. So then,
Ah,
thank you again for joining with us.
okay, thank you, Sarajit.
Right. So,
I want to talk to you later, okay?
right, sure, madam. Yes.
Right.
So, we have actually come to the end of the first day of the workshop organized for the medical officers in pathology. So, to present the closing remarks, let me invite Dr. H.W. Dilante, Joint Secretary of CCPSL.
Thank you, Saraji. I hope you can hear me. Saraji,
Yes,
can you
madam.
hear me?
Yes,
Okay.
yes.
Okay. Thank you. Thank you. Firstly, on behalf of CCPSL, in my vote of thanks, firstly, let me take this opportunity to thank Dr. Sudat Dharmaratne, Deputy Director General of Laboratory Services, Ministry of Health, for joining and encouraging us amidst of his busy schedule. Next, I would like to thank all the speakers who dedicated their valuable time and delivered excellent lectures to educate the participants in view of enhancing patient care. Also, I thank all the participants who joined with us today, and I hope this workshop provided you an insight to become an efficient medical officer in pathology. Finally, I thank all the council members and the coordinators of CCPSL for the support given to make this event a success. And a special thanks goes to Dr. Saraji Gunawardana, Senior Registrar, Cancer Institute Maharagama, for conducting this workshop in a very efficient manner. So, hope to see you all tomorrow morning with another fruitful workshop. Thank you. Over to you, Dr. Saraji.
Thank you very much, madam. So you can join with us tomorrow as the scheduled time for the second day of this workshop. Thank you.